Okay, so I have with me today a very experienced nurse who's a new guest to the channel. Her name's Jenny, and she's been a nurse in the United States for 40 years. And I'm going to allow her to explain a bit more about her background, which is quite extensive. She's been interested in Lucy's case for a while, and she knows an enormous amount about it. So I'll firstly say hello to Jenny and thank you for joining us.
Well, hello, to my friends in the UK. I'm from here, from America. I've been a nurse for 40 years. The first 15 years, I was in a top-notch American hospital, research hospital, that had both, we call them interns and residents and attendings, but you call them junior doctors, registrars, and consultants. So I know the nuances of that. I've worked with, although they're never pediatric, I work with a lot of adult doctors who were on the level of Shu Lee. So I kind of understand that. I did a bunch of years in home care, so I understand the nuances and importance of institutions and things that can make a hospital work that's out in the community. Kind of the most important is that the last 15 years I was what they call a case manager. And basically I wore a lot of hats, but the hats that kind of deal with Lucy is that I had to do a lot of chart auditing, and I did auditing throughout the whole hospital except for the A&E. I did a lot of auditing for the neonatal intensive care unit, so I understand that. But what I also had to do is I had to audit charts to make sure that we were compliant with regulatory things, insurance things, and also safety things. So I had to, if there was something issue like something's not going right, I would flag it up to my manager. And it wasn't so much what I would see in the documentation that I had to figure out as what I didn't see. So I kind of learned how to read between the lines, per se, and do a
Okay,
lot of investigating.
yeah, absolutely. So we're going to get into all of that as this interview continues. But an obvious place to begin is clearly you're not in Britain. Um, so how did you become interested in the Lucy Letby case?
Well, first of all, I'm a big Anglophile. Whenever anything is going wrong or I need a pick me up, I go to Joe Cocker or Eric Clapton for my music. I grew up on Faulty Towers and Monty Python and all the wonderful masterpiece theaters. So it just reminds me of the happy time in my childhood. So I watch a lot of YouTube stuff just because it makes me feel happy. I also, because a lot of what's going on in the NHS mirrors exactly what's going on here in America.
Hmm.
Um, I also have always kept an eye on the NHS, kind of kind of as a bellwether. And lo and behold, one day, like Mark Bates just showed up on my feed for, I don't know, some untold reason. And then all of a sudden, like Tea Break with Tasha, Carl in the UK, and then Black Square Bowl kind of popped up too. And these are four just completely different people and the way they are in their outlook in life. And I was like, they're saying the same thing. So 5 minutes of research, being a nurse, I could figure out this was all a bunch of, you know what,
Yeah, yeah,
total
absolutely.
miscarriage of justice.
Okay, so that's really interesting. So I know that you've studied a lot of the nursing aspects of this case, as would be expected. So could you firstly just give your opinion on Lucy as a nurse?
Oh, phenomenal. I have a lot of respect for her. First of all, I could not be a neonatal nurse because um, I'm too bold. Or kind of thing. She was learning the aspects of being both what we would call a mama bear, being, and I'm not known for being timid, but also having to go switch very quickly and into that neonatal quiet mode too. I think she was beyond her years. I also, when I was a band six, when I was in that my hospital, that teaching hospital, we don't have bands in the America, but it would be equal to a band six. So I did the precepting on all of our new orientees on the floor, and I found her, like, with her age and everything like that, beyond past. I also was just incredibly wonderfully proud of her, the fact that she had advocated, and this was used against her, that she had advocated for a family to put pressure on a consultant to transfer that baby. And I am confident that she saved that baby's life. In addition, that she was young, she went on to get special certification. She was always asking, if you could see, look at her text, look at her datix. She was questioning, as she should be, as we are taught in nursing, to always question, always advocate. We are taught in nursing schools that if we fail, we are literally the last link. The only thing as and I'm sad, I just think she was young. Her only thing I have about her is that she was young and naive. And when you are this age at a nurse and she's still somewhat green. And I think she was only ICU certified only just a few months before this all started. So I don't think she knew who to ask the questions to or direct her questions to. And I think it got back to people, and they resent that. The people that are doing the bad stuff resent that because they know they're doing wrong. So I just wish there was someone older that could have been there to kind of guide her.
Yes, absolutely. Um, so I know you think that someone like Michelle, for example, I know you're aware
Oh,
of Michele Worden, if she had been in the unit, that could have made a big difference.
I have had the privilege of having maybe a couple of Michelle Wardens in my life as a young nurse. It made all the difference.
Hmm.
First of all, there's nothing, she's wonderful so far as her clinical skills and just this wealth of knowledge. Even though you learn it in a book, you have to experience it to really learn it. And it would just be, if my Michelle Wardens, I always had someone I could grab and say, what is this? What can I do? But more importantly, if I needed to advocate or be pretty tough, I didn't get to be a tough nurse until I was much later in life. She was the person that she would say, okay, we're going to go talk to the doctor. I would go and advocate. And sometimes you got to be really forceful with these doctors. She's the one standing behind my shoulder and giving that doctor the look. Or if there was some issue on the floor that we needed to do it, she would be the one coming with me to the manager's office. So just that older, wonderful advocate woman who really, really cares. She's obviously dedicated.
Yes, absolutely. So we met a while ago and we spoke about lots of things. But one of the things that you told me about is something that I have no insight into whatsoever, and it's difficult really to imagine, and that is the impact of a patient dying for the first time when you're a nurse. So I wondered if you could tell us a little about the impact of that and what it feels like, I suppose.
Well, first of all, I was lucky. Unlike Lucy, my first patient death, I was in nursing school, and it was a patient that was exposed to die. We cleaned him up. He was doing everything we need to do on someone we expected to die, and I literally watched him just die. So, and you could actually see the process, but it was a very calm, very, I can understand. I'm not religious, but I can understand people seeing. You can actually see almost like the soul leaving the body. But
Mm.
the death that has bothered me for about 30 something years came maybe I was still green. And this was, and this is, I know Lucy, it's similar to what Lucy had experienced too, to some degree. Now, this was an adult, it was a man, he was immunosuppressed. We threw everything at him trying to save his life, but he got so bad and so septic, he went into something called DIC, which we can talk about later. That's what baby D went in. That poor family, especially the son, just couldn't handle it. I mean, this is his dad was in his early 60s, so he was still relatively young. His son was having an emotional meltdown, and I can understand if there was part of me wishes I knew his name now. I would like to look him up, even though it's been 30 years to see, is this man okay? Now, the other thing but the sight of someone in DIC is just horrendous. The skin changes. But what it is the first time I smelled death, and there is a smell of death that you will never leave your nose, your thing, and you will always think about it. And I've maybe smelled it only one time since then in 40 years, but it just doesn't, there's certain deaths that you just can never, you move on, but you don't get over. And I totally understand Lucy. And what really, really bothers me about this, especially like the Judith Morris and the other, who was the other one that was loved to in the media that just love to say, "Hey, I didn't like how the way she looked, therefore she's guilty." You know, they've never smelt death. They've never looked at death. They may be in that bed at some point, being that patient dying. They may be seeing their father dying. And you know what? If you're going to judge a nurse and what we have to do, now, granted, there are bad nurses out there, and there are probably bad serial killer nurses out there, but you better be 100% sure that that you have it right, and it isn't a gut feeling. How dare you do a gut feeling? And another thing is that, these people that are really fervent anti-Lucy, at some point they are going to be that patient dying, or they're going to have that family member dying. The nurse will come in and they will be professional. They will give them as good a care as they would if that was Lucy right there. And I think you have to, what other profession has to do that? Very few.
Not many, not many. I mean, spoke about this with Michelle previously, but you have to have. It's such a strange um, perspective and outlook and personality that you have to develop in a way because you have to have the caring side, but you've got to be able to compartmentalize that and be, as you say, very clinical, not cold, but tough. And it's
Yeah, no, sometimes you have to be cold to the right person that's cold.
mm,
Meaning, if I've had some breweries and Jerams and some of these things, and I'm not also going to give the executives, some of the managements too. Um, they're to some degree a part of this too. And you have to be cold, and they would call us a bully. That's what Martin Pittman, they claimed he was a bully. Well, he was just being an advocate. And that's what's actually is happening now in healthcare over here in the United States. Anytime you try to advocate or do that, you're being accused of being a bully and
yes,
stuff. So, but then you have to switch that on in a minute and then be that caring, that compassion to that patient that's dying or that family member and stuff. Oh, and also to your fellow worker that's dealing with whatever too. You got to kind of do that. But also there are workers here, and I do hate to say this too, that there is a component in a hospital, even within nursing, where there's the doers and the non-doers. So it's multifaceted and stuff.
yeah, absolutely. So I know from our previous conversation that you're of the opinion that you've worked in good hospitals and bad hospitals during your career. So could you talk a little bit about the difference between the two?
Well,
Um,
I hate to say this, a good hospitals here have gone past what they would, and I'm sure the NHS is the same way. What was that ethic? What was that ethos that they did? What was the thing that caused it? Here in the United States, most of them were religious organizations. So, but we no longer have those religious orders and stuff doing it. Now it is, even though they do claim to be ethical, and many of them are, but unfortunately in the United States, it's more of a, oh my God, are we going to get sued? Or are we going to lose our certification? So if we don't have Medicare certified, which is the federal funding, the hospital's closed down. So they look at that first. Although when I worked at the hospital, no, we didn't do unethical things, but you kind of have to do that. And it's almost like someone is cracking the whip. And it does make for, I hate to say it, but it does make for a better hospital or make you more risk management averse. I had the bad hospital I worked at. Now, first of all, the good hospital I worked at, there's a certain line that you can go so far as regulations and legal per se. They were terrified to even go close to that line. Where that bad hospital I went through, they would go to that line, and they had no problem going to that line. The good hospital I worked with, if someone would have done what Brewery did to that liver, oh my God. Oh my God. And I worked at a hospital, the bad hospital I worked at, we had a guy that punctured a patient's colon. And that patient ended up getting millions of dollars, and the hospital's closed down for financial reasons. But we saw, and I even complained to my manager, who was complaining to the executive. He was a wonderful manager, that this guy's got a substance abuse problem. And it took that for us to finally get him out and for him to finally lose his medical license and practice too. But again, if there was any hint of any of that, again, at my good hospital, again, we kept an eye on it. And also, we weren't as protected. We were protectant of the doctors that were phenomenal. Um, that just had this wonderful reputation. A lot of them came from the teaching hospital. They were tired of academic and they came to what was a community hospital. My hospital was about kind of a lot like Countess of Chester in size, and it's a community-based situation. Um, Again, and they were wonderful. In fact, some of them, as they got older and they couldn't do what they were doing because some of them could work magic, they would find a place for them. So it would be safe so they could still do what they're doing, to still have that mental thing, but it would be a safe situation with the patients. And that didn't happen with John Gibbs. But and again, in the bad hospital, if you were bringing the patients in, raking money off it, we don't care. We don't care. It was all about the money on stuff. So again, there's just, and again, when I look at like a lot of those CQC reports, well, we have something called JACO here and a few other things, but mostly it's JACO that's like our CQC. It is not part of the hospital system. It's totally private, which helps. And if you don't meet their inspections, and their inspections are a lot like the CQC inspections, you're toast. And I'm seeing a lot of these hospitals here, and not only was it Countess of Chester, but Arrow Park too, that again, we were always if something a blip would have happened, we were terrified even before they came, and we cleaned things. Not that we needed to clean things up, but it was like the General Montgomery coming to inspect the troops. Everything was, but where they had bad hospitals, like, we'll deal with it when they get here. And if we get a bad one, well, who cares? We're making money, kind of a situation. So and you know what? It's like the executives in the bad hospital, boy, they drove the wonderful cars. They had beautiful offices, but the troops, nah. Yeah, we were the mere peasants.
Yeah, yeah, and that does seem to be something that occurs in the NHS, and maybe particularly at the Council Chest. I don't know, but it does seem that people at the bottom of the food chain, as it were, don't get treated very very well.
Oh,
Um,
nurses are the peasants. And here in the
yeah,
United States, if something's wrong, they usually go to nursing first, unless it's a broken window. Unless you can plant it on maintenance, it's usually a nursing thing. And they develop the processes, a new process to do this. And again, and a lot of it's coming from kind of nursing management. And the cream of the crop, the cream doesn't rise to the crop. The cream doesn't rise to the top here. And I'm sure it's the same with the UK. It's one of this, I got to get out of the floor. A lot of it is an attitude, I'm too good to work on the floor. So therefore, I'm going to go into an office or do an office and management kind of a job, and do that. And managers and executives used to be, you'd see them out on the floor now and then. I used to have a one head of nursing at my first hospital. Once a month, she was an old ICU nurse. Once a month, she would actually do a shift in the ICU to remember what it's like to do that. This other hospital, she would make her rounds, and if she would see a load of laundry out, she would just pick it up and put it in the laundry chute just to help the nurses. That would never happen nowadays. They don't they don't touch dirt, and they don't want to smell the smell of a hospital, and they're stuck in their offices. And and I can see easily it's all about data entry. It's all about, I call it they worship at the house of Saint Microsoft of the Excel spreadsheet, so they can honor the altar of data entry. And it's just one meeting after another, and let's just do another process and put it on paper. Nothing gets done.
yes, yes. And I know in addition to that, you said the same to me about doctors. Obviously, you've said it in this interview already that there are good doctors and bad doctors. And you also cited to me the example of Martin Pittman as being a good doctor. So could you explain some of the differences as you see it between good and bad doctors?
Well, first of all, my favorite doc, first of all, Martin Pittman, excellent. We had a in our obstetric department, we had a Martin Pittman, and we had wonderful outcomes. And that's why in my last job, that neonatal intensive care was outstanding. And it had to mostly do with the fact we had a Martin Pittman like person. His personality was a little bit different, but he was the same. It it's like they're like, and a Martin Pittman is someone that's, think of him as an artist or craftsman. They're producing this work of art. They want this, they want everyone to look at this work of art. They want this to last for thousands of years, and they're proud of it, and they work at it and do it. But my favorite doctor of yours was Ray, the radiologist. And the reason is that he was self-reflective. He knew exactly where his weaknesses was, and you can just tell on a thing. He even did his own deep dive into his own processes and stuff like that too. That is a phenomenal doctor that knows where his limitations are and does whatever they can to improve himself. So Ray, the radiologist, is wonderful. And another example was Colin Morley. I don't know if you know what a god he is in the neonatal,
I do, yeah.
literally a god. I mean, if there's ever a man that understands resuscitation and surfactant, that it is. I mean, we're talking world renowned. And I really take heart in the fact that someone like him, and he is a Shu Lee, that is, and that's a good doctor that is like, no, I'm going to fight for the nurses because I know how important they are. And in fact, he took time to talk to you. That is phenomenal, phenomenal.
Yeah, I mean, it was a real privilege. I mean, he said some incredibly
Yeah, yeah.
nice things to me, which are very humbling. But yeah, it's very interesting to hear outlook. I mean, I think the thing that I would reflect on myself is you talking about the lack of, the self-reflectiveness. Because we see in the Countess of Chester, it's very obvious from what we know now that the doctors, the pediatric team, were just not willing to even. I mean, they do claim they looked at their own practice, but they
Oh,
they did that very reluctantly, didn't
oh,
they?
no, 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 they didn't. I am going to do this, and we can do a deep dive later, but I found many things where,
Yeah.
breweries did all these thematic reviews and stuff like that. He made both indicted and unindicted babies look different than what they were. So we can get into that later. But no, they claim to be self-reflective. No, they weren't. But another thing about Lucy that makes a good nurse is self-reflective too. And you can see that in those post-it notes. If that happened to me, I would be thinking the same thing. I killed him.
Mm.
You know, and a good nurse is someone who can't, when they clock out at 4 o'clock, don't clock out. And you can see in her text messages, she's worried about things. How is this baby doing? Oh my God, this happened, this and that. Again, that is, you take your job home with you, which unfortunately it makes a lot of us nurses are leaving, and I even left at age 60 a lot early and stuff like that. It leads to a burnout kind of a situation. But again, all of her things can be explained by just being just like Ray the radiologist. What am I doing wrong? Did I do something wrong? Even, and I know she knows now that it wasn't her fault. She's still, I can guarantee you, self-reflecting at that one maybe little thing she wasn't perfect at and stuff.
Yeah, absolutely. Um, so you also told me that you worked in a hospital during your career, and at that time there were three sets of triplets, two sets of twins in a unit that was similar to the Countess of Chester. And I know with regard to this, you have some comments about the layout of hospitals and why it was so bad at the Countess of Chester. So could you outline some of the reasons for that?
Well, first of all, let me get to my notes here. First of all, our unit was okay. So we have 4 levels here in the America where you have 3, and it's just kind of like that. It's just spread out a little more. That level 1 is just your basic. The baby doesn't even need to be in a nursery, and level 4 is Great Ormond Street level. And so we were a 3. And we were attached very closely within 15 miles of and again, an incredible neonatal transport system too, that baby could be sent there. Our limit was 28 week had to be at least 28 weeks and or at least 1,000 grams. And it was a clean unit and well oiled, well functioning. Had all those four components been, a lot of these babies would still be alive. That especially that 28 week and 1,000 grams. That made all the difference in the world. So we had a high risk guy like Martin Pittman, and he always got multiples. And if anyone was a multiple, they would go to this guy. He had delivered three sets of triplets and two sets of twins at the same time. Plus, we have a bunch of singletons, and we were busting at the seams. And when I would go in there to do some chart work, I would see it was like organized chaos. But every single one of those babies did not have a crash, did not have a bad event, all went home, it was a beautiful outcome. And I remember one time. I went in there in the morning and I'm looking at the neonatologist and I'm like, "Are you okay?" And he's looking at me, he goes, "I've just done 24 straight." I said, "Weren't you just here when I left yesterday?" He goes, "I haven't left." That man put in a 30 straight hour day. And that's what you do. That's what you do. You don't see that with the Countess of Chester. And I'm really upset about it. I know that email that was Alison Timmis's said or whatever, sent that, "Oh, one day I had to do a 21-hour." Well, you know what? That's what a neonat or that's when someone you do it. And again, that neonatologist never complained. Now he looked a little haggard there for a while. And again, once that whole thing was done, but he I don't even think the man even went to go get lunch.
Yeah.
But he did it. He did it. And there was more, we'd have more than one neonatologist when we're that busy. But again, they were just all dedicated and the nurses and the doctors got along beautifully. You couldn't see a divide. And in fact, you could ask a doctor, and there could be 20 something babies in there. You could ask a doctor, they would know about all the babies. Just one doctor. You'd ask one nurse, she would know about all that babies. And that's unheard of on a regular adult unit too. It's like they all own, even though they're not assigned to that baby, they all own that baby and they all feel that is their baby and stuff. So it's a team effort. Wonderful. And in fact, they worked incredibly well with the obstetrics. They knew when these multiples were coming. They knew everything. In fact, that our Martin Pittman guy, he rarely had an emergency C-section. He knew exactly how to plan these things for the perfect outcomes. And if you're looking at a lot of these cases here, you see emergency C-sections on a lot of the Countess of Chester. We didn't. I can go through the whole list of what I didn't see. I never saw a neck. I never heard of a baby that needs CPR, except maybe the baby at delivery, which you would expect. Only one time did I see a baby that needed what they call secondary antibiotics. Sometimes the baby gets infected with the mother's flora and they need a certain antibiotic and they may have to go to a secondary. And that baby did fine, and that might not have been our fault or anything like that. It may not have been contaminated, it just happens. Um, we, a lot of these medications I never saw. A lot of these antibiotics that I'm looking in here. These are antibiotics for MRSA that they were given to these babies, antibiotics for meningitis. I never saw meningitis. Um, I never heard, and I know I would have heard through the grapevine if there was a transport issue. I found babies here, unindicted and indicted, that the transport team said they were coming and it took them 12 hours. I heard when they needed to call that, and I never heard the neonatologist complaining when they had a baby they needed to transfer, like, "Oh, they put me on hold." When they would have to call that in. There was baby I. They called Liverpool. They called Liverpool and they put him on hold for 7 hours. And that baby was so sick. And I'm not blaming the Countess of Chester on this. That baby was so sick and needed a drug that should only be given in the ICU. Dopamine plus dobutamine added. That's how unstable that blood pressure was. That was absolutely unheard of. Um, any hypoglycemic things. It was usually a baby that was out on the floor, regular baby. Um, and that couple of hours later, a day later, you would expect it has to come in, it's got some hypoglycemia. I never heard of a baby needing insulin. So we didn't have septic kits, in other words, and stuff. We isolated anytime there was, we had a special room that they ended up building that, and it didn't cost them much. The baby that if there was someone that had maybe had a RSV or something, they put them in there. But I don't remember any of our babies being on something what we would call contact isolation, meaning they had a C. diff or they had a staph infection or something where you would need to gown and glove up and you need to put those babies in another room. A lot of these babies here, there was no isolation, no contact isolation. That incubator next to them was just a few inches away and stuff. So it just, I made a list somewhere. We can look at it later of what I didn't see. I didn't know with a lot of these. I learned more about neonatology, um, studying and looking at the Lucy Letby situation than I did 10 years. I did 10 years of chart auditing for them. So there was no drama. And that was the floor when again, I would cover for people that were on vacation or holidays. So I would be in this floor this week and another floor another week. When I was put on OB and NICU, I was usually bored because it was so well run, so well done. And I used it as a time to catch up on other things where like the adult medicine floors, and I was busy and doing overtime. So again, it's such a different planet. Now, I do like to stress to all of you here that in America, my unit was the exception. We have our share of units like the Countess of Chester. And I can see situations where, and we don't have very good infant mortality and maternal like you guys too. We have a problem with that too. So and our justice system, well, we like to execute people. So,
Yeah,
again,
we're not
this
taking
isn't the UK here. I mean,
we're
we
not
have a lot
taking
to
any of
do with.
we're not taking any of your comments personally. Don't worry.
No, no, I
Yeah,
don't want you to. In fact, I get a little upset, and I try to. I see a lot of your comments from the people from the UK. It's almost a self-flagellation. Don't do it. It's bad here too, and we even have a serial killer nurse here too that has been in Texas, and it was around the time of Beverly Elliott, and I'm even thinking now. I think that woman's innocent too, and she was used as a scapegoat for a bad hospital too, and a bad doctor too. So
mm,
and Mark McDonald, that's where he got his training from, was the
yeah,
Innocence Project here in Tennessee.
yeah,
So, and he had to deal with a lot of people that were executed and they were probably innocent. So,
mm,
so
yes. Yeah, so that's fascinating information. Another aspect of the hospital that I know you're critical of is its vulnerability to infection, which
oh my gosh.
we're all aware of. So, can you tell us why the Countess of
Okay,
Chester
well,
was so
let me
vulnerable
get
to
to my
infection?
notes. First of all, the layout of that nursery was something that we would have had, and I know the hospitals were in 71. Well, I went to nursing school in the 70s. That is the nursery that's built for a regular well baby nursery, and it never changed. That nursery was built, or is that built nursery as it was then, was just an incubator of contagion to begin with, regardless of the Pseudomonas. First of all, there was no hand washing, no what they call foaming in with an alcohol unit before you even went there. I mean oh my gosh, here in my thing, we had an infectious disease nurse that would stalk the doors to the NICU and try to catch you not foaming in or doing it. So we had that. Okay, so here's the layout that I just find just unbelievable at the Countess of Chester. You first of all, you walk in the one area that anyone can walk in, and I believe that's coming from the pediatric ward, and parents would come in here too. The reason I say the pediatric ward, that is really bad because those consultants were dealing with all the pediatric stuff and bringing it into um, the unit. And I don't think they're washing their hands. That's unheard of in the hospital I worked in. You were neonatologist, you stayed in that, you delivery, the NICU, peds totally stayed away. because they knew they were bringing in. There was babies that had RSV. There was babies that had MRSA that may not have come from out there. There was a baby with strep A that was an unindicted baby, and that's strep throat. And Shuli said he believed, I think it was baby G had adenovirus, which is basically a stomach bug kind of situation. So you walk in and you're bringing it in, and what's really important to remember is what's on the floor. That is the filthiest part of the unit right there. So I walk in, I don't wash my hands because there's nothing to wash my hands. Right to the left of me here is what we would call the dirty utility room. You call it the sluice room. That should not be anywhere near a main hallway because you're just walking that stuff in and out. Okay? So that's in that hallway. That hallway also has, I think that is where the drainage of the they had to put the nappies in the ceiling going out there. It's also a big charting area too. So you walk straight down that hallway, and what do you get? You should have gotten room 4, which is the Wellessa baby. You get room 1, right off the main thing. It's right there. And on the side of that, there you have the doors to the maternity area, which is just nothing but it was just they were having sewer leak by sewer leak. So you got 2 dramatic entries right into your most high capacity unit is right there. Another thing is that, and of course it would have 2 sinks in that big room that had Pseudomonas. That's really bad. And the reason it's even worse is that all the medications for the unit were in that room. So any baby that in the unit you needed, first of all, you would have brought in stuff from all the other rooms. That room should have been as far away as you could. And then you grab the thing, you're grabbing probably Pseudomonas contamination stuff and bringing it to room 3 or 4. And then in the hallway, and again, there was no designated, it's unheard of not to have a dedicated medication and a medication room. Real important to have that, and you have that off of the things too, because a lot of these things, you're picking up vials of insulin or vials of this or that. You got to keep it as clean as possible. You want to keep it away from patients as much as you can. Another thing is that you need that medication room. That's where I would set up my IVs. It's a most clean room in the whole thing. They were setting the IVs up in the hallway, which is probably the filthiest of all situations there. And then on top of it, they kept, oh my God, breast milk in the equipment room. Okay, breast milk bottles are handled by a lot of people. We all have staph on us. We all have enterococcus, which is poo. Even though we wash even unless you scrub your hands, super, you have it. So you have a lot of people handling these bottles, nurses handling the bottles, and they're keeping it in the equipment room. This is the room that you would keep your trays. It's a certain sterile tray that you would use for your IVs, all your intubation stuff, all the invasive stuff. Even though technically when you open it, it technically is sterile, but it's still contaminated on the outside. And it's so easy to get cross-contamination. And then what's really upsetting is that the incubator that they needed, it's a special incubator you would go if you had a basic baby in maternity or the OB side, take that incubator, put that baby in maternity, that was kept in the, it was kept in the hallway. So you're just bringing all this stuff back and forth. And then would have been absolutely unheard of. I understand there was one period where they had all these infected babies that needed IV antibiotics. They brought those babies in to the unit. So they were just bringing infected thing in and then bringing it out. I just cannot get over that. Again, we had a totally different separate. Ours was a big L. In that kind of that L where there is no L, that was completely separated. That's where we would have had all of our clean utility room, dirty utility rooms, hand washing and everything. And then you'd have to enter, and then you would go into this L room. And then the short part of the L is where we would keep the high acuity babies. So just, you couldn't walk there, okay? And it was all about keeping the foot traffic away. And then the more well you got is, you would kind of move down the thing. And we even ended up building a couple of isolation rooms just in case we'd get an infected baby that needed, so you would put that baby in there instead of having it this far away from a crib. And another thing is that the nursing station's all in there. Everyone can to some degree, see the babies to some degree, so it was monitored. And our neonatologists, they were there 24/7. They didn't leave that room unless it was to go for a delivery or it was to go get lunch. Did not leave. In fact, they didn't have there was no sleeping cots or anything like that for any of the neonatologists. They worked in shifts and stuff.
Yeah. Well, that's very interesting, very, very insightful. Now, I know that you've touched on this a lot already, but I know you have some views on infection and sepsis on the unit. So could you possibly
Uh,
share those as well?
okay, well, first of all, I don't think a lot of these moms, when you look at the thing, they were, and rightfully so, they were in the maternity department for a while, the labor ward, whatever you want to call it, several days prior to delivering. So that put them at great risk of getting these, what they call nosocomial infections, which is a hospital acquired. We're talking MRSA, Pseudomonas, Enterococca, Acinetobacter, all the stuff that you don't want. Okay, so they deliver a baby and they deliver a baby and the baby looks septic. The problem is that what I'm seeing here is in through the thing is that they're giving the baby antibiotics, but they're not giving the baby correct antibiotics. They're giving the baby what they would call a penicillin and a gentamicin. Those two antibiotics cover the flora from the mom, the regular stuff that we would expect from any mother in the most perfect circumstances. That would be Group B strep and E. coli. Problem is, all these other stuff and all those other things that I'm telling you about, the baby could have. So they're putting this on baby on antibiotics, and they're saying at the trial, well, it was already on antibiotics. Why did it crash? It probably crashed due to it could have gotten it from the mom at birth, or even the mom was colonized when she went to do it, or from the sewage or anything, and that's called secondary sepsis. And again, it wasn't until Brewery, of course, he did, and don't get me started on his thematic reviews. He did a deep dive in what we need to do. After baby D, he didn't, he's put on the formulary something that would use for meningitis. And I've seen two unindicted babies that had that same antibiotic that you use for meningitis. He also looked at, goes, oh, wait a minute, we weren't giving penicillin every 8 hours. I mean, this all should have been before, years before. Oh, maybe we should start giving penicillin 8 hours, and that would be for coverage for the mom's flora. And then he's saying, we're giving gentamicin too quickly. Gentamicin is something, again, that could blow the kid's kidneys out or its hearing out too, and they're giving it too early. Um, and I'm also seeing a baby that's unindicted, and we can do the deep dives later, that was on, oh my God, serious medication, teicoplanin. I can't pronounce it correctly. It is, okay, it is a medication that you give in place of vancomycin, okay? And anyone in the healthcare field knows vancomycin is one of the last choice medicine. And they were giving it with the medicine you would usually give with a meningitis. Those two in combination are given for serious, and I mean serious, antibiotic staph infections, MRSA, and then there's another one too, nasty. So that was an unindicted baby that I found. So just so you know, they were aware. Just all the stuff, and again, this is all I'm finding it through Thurwell. Where are the cops? This was easy to find out. And even I don't know how Dewey didn't look at this too and see just me, little Jenny in our basement here, that's a grandma, can figure out these antibiotics and what they were used for. They can't. And again, it was just, and I've seen some unindicted babies that were mysteriously transferred for stuff called, first of all, congenital pneumonia. That's baby gets infected before it's that, or pneumonia and sepsis, or some of it was hidden by it was multi-organ failure. That just tells me probably infection. Just absolutely unbelievable. And again, and again, and my skill, I honed in that when I had to kind of monitor some of these, and I would monitor bad nurses too, and bad doctors and bad practices. It's what you don't see, and it's what I'm not seeing, or it's how he's phrasing it. He's phrasing a baby, and this was an unindicted baby that he was the assigned consultant. It was an unindicted baby. He made it look like the baby had metabolic acidosis due to a delivery problem. It was due to resuscitating, and baby ended up having a lot of cardiac issues that I don't think he looked at. And again, but again, I can point that out to you later how he was able to hide stuff and everything. So it's just unbelievable. But again, and again, my friends here, when I talk to them about this, we're all in agreement. Yeah, we can see this happening in some hospital here in America too. So,
Absolutely. Yeah, so at this point, we're going to do a demonstration, I believe.
oh,
But
okay.
do you have your syringes?
I have my syringes.
Okay, so Jenny has several syringes in her possession, and so we're going to discuss the embolism and do a quick demonstration.
Okay. First of all, many of these syringes, and this is a small syringe. This is what I use for my cat. I have to give her injections. Are covered by a wrapper and a thing, and you open these things up, and especially for the larger things, you hear people opening these up. Okay. So how in this thing how someone couldn't do it. Now Dewey in his wonderful demonstration, we'll get into that later,
Yeah.
showed you a 3 cc syringe. Okay, look at that. That's easy to do that. Now, Dewey in his testimony and Sandy Bowen said it had to be 5 cc's for the air embolism for the IV. Well, that's 3 cc syringe. So this is easy to do. Okay. So first of all, it was an easy demonstration for him. All right, so let's just say it's true, you need 5 cc's for the thing. You would need a syringe like this, and it's probably remember, it's in a wrapper like this, okay? Now, I have small, tiny hands like Lucy too. It's not easy. Versus a 3 cc syringe, it's easy to pull back, but it's not easy this. Plus, you have to hold the thing too. Now, just getting into an incubator, and again, is not easy. There's 2 portholes here just to get into it. And just an FYI for baby A, Dr. Wood, who was it was the junior doctor that was at the resuscitation of baby A, they had a hard time getting into the incubator to start the CPR on this baby. Okay. So now we're going to, in order for Lucy to have, and I only have a 30 cc syringe, I would need a 60 cc syringe. But so think of something twice the size. This would be the one. And again, they're hard to pull back. Lucy would have to have only do this one-handed. Just to get that in, that's the feeding tube thing. And plus you'd have to clamp it a certain way and then put it back in and clamp it. It again, oh my gosh, when I tell people about the air embolism and stuff like that too, it's a joke. It's an absolute joke. And I'm just amazed. I remember that you had that Officer Watts on saying, how did they not? It's easy to get a hold of these things. Did not have an officer just physically doing and here in the United States, and I'm sure it's in the UK, many nurses are married to cops. There's not someone in the Operation Hummingbird that doesn't have a sister, a mother, a wife, a spouse at that. Okay, let's play here. There was no playing. There is no way Lucy could have done this without people seeing.
Yeah. Yeah. I mean, that's always been my opinion.
Yeah, it's funny. I mean, and he's, imagine putting a syringe that's this size, twice this size, hiding it in your pocket like Dewey says. No, no, it won't happen. And no one's seeing it. And plus, if she was doing all this stuff, well, what was the inventory of the syringes? Was anyone, I'm assuming the NHS is even probably due to cost cutting things, they're very picky on, probably more picky on their durable medical stuff and they're keeping a close eye on the count, they would have had all these missing and someone would have noticed. Because why are we reordering all these? What for? And stuff like that too. I guess Dewey would have said she was using dirty ones. So,
Well, they didn't even try to have an audit for the insulin, never mind the syringes. So
yeah,
I don't know.
yeah, the insulin things. In fact, I never really got deep dive into the insulin because we never had it.
Yeah.
It sounded so crazy. And I always like to stress, and we've always were stressed in nursing school, your specimen is only as good as the person collecting it, first of all, the person that is transporting it to whatever lab it is. The lab could be on site or the lab could be miles away, and then the person that's processing it. So there is at least 3 to 4 people. That has to be perfect in order to do that. Another thing I'd like to kind of stress, if that's okay, is that the a lot of these babies, and they kept saying, well, the baby's cultured negative. Well, first of all, blood culturing on a baby is very difficult. You have to have at least 1 cc, and again, you have to do it at so many sites. They're only checking what they call aerobic organisms, not anaerobic. And anaerobic, and adults, you do aerobic and anaerobic. It's rare to have an anaerobic bacteria in a baby. That's a problem because since there was all this sewage, those babies could have had something called C. diff. And C. diff looks, it's not one of the big issues with neck, but it makes you look appear as if you have neck, as the same kind of symptoms. So again, also, and another thing that I was unaware of, and again, with my research, I found out that since Pseudomonas is everywhere, a lot of places, a lot of times if they pick it up on the thing, unless they know the unit is having a Pseudomonas problem or the hospital, um, they would just say, oh, it's a contaminant. Also, certain staff, and again, you can't draw the 4 bottles that you would need on adult. You can only draw maybe a 1 or 2 bottle on the baby. So they may have just went, oh, it's a like a skin contaminant. Well, there's a lot of staff on us. It's skin contaminant. We're fine. But if it gets into the bloodstream, you're in trouble. So I can see, and again, the lab that I'm looking at too, it wasn't an actual lab at the Countess of Chester. They took out the lab and they made it centralized with Rural WIRRAL teaching hospital. So it was one main lab. So they had a satellite, and I have to question, and I don't have any knowledge of this, but I have to question: was this lab? A lot of things didn't work in the Countess of Chester, and again, the executives allowed a lot of people to have that. I don't care. The other person doesn't care next to me. They don't pay me to care. I'm just doing my job. How good was that lab? Because there are some babies in here, both indicted and unindicted, that I'm shocked that didn't have something cultured. And another thing that they weren't even noticing CQC thing is that the refrigerator that houses the placentas, they weren't maintaining it. That's a big deal because you have a placenta. First of all, you'll need that placenta afterwards. Most of them they just throw away, okay? But you need that placenta. First of all, if you need to do any kind of like a genetic workup or something odd, but you need that placenta to culture. You want to save that culture. You want to culture it on one side, which would be the baby side, and you culture it on the mom's side. Then you can tell, is this a bloodborne thing that the baby is going to get, or is this just coming from what they would call an ascending? It came up the womb kind of thing. And they just let the temperatures go. It sounded like almost like there was nasty, almost rotting placentas in there too. So they weren't culturing their placentas, which is big, big, big deal. And another thing, like, oh, those parents, some of the stuff it was heart-wrenching, but like I'm reading like the father for baby D saying even the breast milk refrigerator that was in the equipment room, mind you, there was curdled milk in there. People and then CQC told them they were not keeping their eye on all their fridges. They got cited for it. And this was, I don't know, it was 14 or 15. I think it was like 2015. I can't remember. I looked at the 14 and the 15. But again, there's, a lot of issues with that.
Absolutely. So we've mentioned Dr. Evans already and his demonstration in the Channel 4 documentary. So I'm now going to ask you, what did you think of that demonstration?
Well, I have to ask you, isn't there some sort of a Red Nose Day comedy relief thing on TV
Yeah, it's
in
still on
one day?
TV. Yeah.
I,
Yeah.
I thought this was a comic relief, kind of a Faulty Towers Monty Python thing. Oh, I am saving this for my nurse friends because I was on the floor laughing. And I can guarantee you there isn't a nurse in this world that isn't. First of all, his setup is for an adult. And he's got the bag that's a liter bag. That's only for an adult. And he says this is an exact pediatric setup. Well, no, you have a 50, that's 1,000 cc's. So you have maybe a 50 cc, at most a 250 cc. It shouldn't have been this big. So it's hanging from a chandelier. And you can see how easily, and again, the setup, the tubing might be the same, but if you remember Ray, the radiologist, his pictures of that baby, you can see how tiny the lumens are of those micro. I mean, there are just a fraction of the size of that too. So just trying to even push a med into something that lumen would be difficult. Again, oh my God, it's hilarious. And I can guarantee you, any nurse that's had any contact with him right now is laughing hysterically. It really was a red nose comic relief picture.
Yeah, absolutely. Um, so one thing that we were discussing previously was the notion of babies collapsing at night being vulnerable to that, which is something that other nurses have mentioned to me. But you also mentioned as well that you noticed in the court case that there typically weren't collapses and deaths in the middle of the week.
No,
So could you explain the significance of those two things?
yes, okay. So a lot of the collapses, well, first of all, night shift, our circadian rhythm, most adults die at night. I mean, it's just part of it. But what I noticed, I did a deep dive both on the indicted and unindicted babies too. Vast majority of them have from a Friday evening to a Monday morning prior to business. Okay, that is the weekend isn't just Saturday or Sunday. People, you know, kind of clock out on Friday, and they really don't think about anything until Monday morning. Most of these things were happening. Only two babies that I've been able to find that happened during the week that was during business times. Baby O, which is a Thursday, and an unindicted baby that we'll get into it another time. That brewery was assigned to, they had cardiac issues. Amazing. And he was the consultant of the week too. So again, the feeling I'm getting, and feeling is that these are pediatrician, not neonatologists. Their whole their whole thought is that pediatric ward, and this is an afterthought. Oh, we'll just let we would call them interns and residents deal with that. We're going to figure on the pediatric ward. Many times when Ravi should have been there, he was on the pediatric ward instead of there. This should have been his number one priority, with the pediatric ward being second. Or God only knows what was going on there. So their mind is on pediatric, and I'm just so unbelievable. And this isn't that long ago, of the processes and stuff like that too, that they were not even close to being up to date to 2015 regulations, especially in the antibiotic things. They weren't even aligning themselves with Arrow Park in their antibiotic protocol. That everyone should have been doing the same thing. So obviously they weren't reading whatever the latest literature is for, doing antibiotics and stuff like that too. So again, their mind is there, and again, they just can't think past. They think of these babies. Okay, we're not supposed to think of children as little adults, but you definitely never ever think of a neonate as even a little full termer or a child. And they were regarding these babies as little babies instead of, well, it's 5 pounds, and usually I deal with 20 pounds. And even in the medication, And again, and I'm looking at a lot of these resuscitative medications. I don't think they were giving the correct dose. There's a specific way just for neonatologists, neonatology, and even just for the preemies that you have to calculate. It has to be this versus that. It's a there's a massive differences. So I don't even think the resuscitative medications were wrong too. Another thing is that they were giving so much adrenaline. Okay. Michael McConville, if you listen to his podcast, was apoplectic about the adrenaline. This is a jump start. Think of it as a jump starter for your heart. Well, they didn't even realize then in babies, it isn't the heart that stops first, it's the breathing. And if they would have just gotten that breathing together, they would not have needed to give that adrenaline. Plus, oh my God, and this is where Lucy had may have made a mistake. On one of the babies they resuscitated, they gave it multiple doses in a peripheral line. Think of it in here. I know, as a nurse, under no circumstances do you give adrenaline in a peripheral line because it causes that to collapse. She even noticed that baby lost completely wide hand. Had that baby survived, it could have lost its hand. Just so basic. And then they were having problems getting in lines. Well, again, there's a way to solve it. There's a way to put a line in the bone. It sounds bad. But that needle to get the bone, they didn't keep it in the neonatal unit, in the resuscitative thing. They had to run out to the pediatric during a code to get that needle and bring it back. And of course, they're just bringing germs back and stuff. And there was like, oh, so many things. And so many things I'm seeing in Lucy's Datix, not only Lucy's Datix, but some of the nurses that she hung out with. And there was a group of nurses that I don't want to get into now, but I'm not too happy with too. But she had that good core group and just all the complaining, or you can just see a unit that wasn't managed well medically, but wasn't managed well nursing wise either.
Yeah, and you just mentioned getting lines in. So, do you have an opinion on the way that intubation was handled on this
You
unit?
mean IV lines or the intubation?
Well, let's talk about intubation.
Okay. So a lot of times it took them several attempts to get in, which is not unheard of. Okay. All right. We'll give them some slack on that. Sometimes, especially the size of the baby, but at a certain size, again, I think they were having problems with 30 weekers, which kind of, that's not a micropreemie. Okay. And it was always the first and second, we call them interns and residents, junior doctors and registers that have the problem, and the consultants kind of right there. And again, there were times like, and again, there were baby N was hemophilic. They had two consultants and two registers couldn't get it, and they had to get an ENT in from Alderhay, and they didn't even need that ENT. The guy got it right in. Dr. Ravi, he has a lot of problems with intubations, especially with intubations. Apparently, and I didn't know this, but Michael McConville says it's known in the pediatric community. You never use a 2.0. It's too tiny. You use a 2.5. He didn't know that. I'm shocked at that. And even more shocking is that the bag that you use for a baby, sometimes it's a low, you don't want to give too much pressure in certain babies. He didn't know that this was a low pressure. Sometimes you have to give a high pressure bag, and he didn't know which one to use. Baby, and it was the famous baby K. Again, he had to be called in by his register. I think wasn't it a 25 weeker, which is a micro preemie, that says, I've never seen a baby like this. You have to come in. So he was literally forced to come in. He was not the one to intubate it. He let the junior or registrar do the thing, and it took several times, and they forgot to give the baby surfactant. Shuli saw that. That is unheard of that you didn't give surfactant. That's the thing that you give down. It does with it kind of opens up the airways and keeps it from collapsing. And then the whole, well, the whole thing with the baby K where he thought Lucy was doing that and he was hearing the alarms. No, you know what he was doing? And this is what I'm thinking. He was like going, he called the Liverpool to come pick the baby up, and he was going, And I bet that transport team says, what's the size ET tube you have? And he's like, 2.0. Or he was thinking, he probably said 2.5. And then he's realizing it's a 2.0. I am surmising that's when he went into and of course the alarms were going off and stuff like that. That's what I was thinking. Oh my God, I can't have this transport team know that I don't know what I'm doing. And that baby died of multi-organ failure days later. And even, I think, was it no, it was Aero Park that picked it up, not Liverpool. I think Aero Park in their thing said this baby might have been able to survive in the thing too. So I'm just appalled at all the attempts. And another thing too is that they didn't know, and Shuley mentioned it too, and so did Richard Taylor, that you have to be very careful in the pressures because these tissues are so thin. They literally were blowing these babies' lungs out because they were putting it on too high. And again, they weren't reading Colin Morley's research. Colin Morley, besides the surfactant, he was really into, okay, maybe we don't have to intubate this baby. Maybe we can just put it on a CPAP mask. And that would save so much. So there was a whole push to, instead of intubating, maybe this baby can do fine with CPAP. That's where Colin Morley is incredible if you read his research into that. And they were just so putting things down these babies when they could have been doing CPAP. And we know with baby O, um, it, and we thought it was just was it UA, whatever, did it, the registrar. I
Yeah.
just found out it was Brewery was in the intubation too, so he knew darn well that that baby was put on too high of a pressure. Not only so he was part of that baby's thing was blown up. And just an FYI, I never knew what CPAP belly was until this. It just never, it just, if it happened, they caught it before in my unit. So CPAP belly was, yeah, I guess it happens and it may have happened at the higher, the children's level thing, but we had 2 pound babies, we had 28 weekers and stuff like that. We never had CPAP belly. So
Interesting. Interesting. Um,
you wanted me to give you my opinion about the IV stuff?
yeah. I was just going to
Oh,
say,
oh
fire
my
away,
God.
fire
Oh my
away.
God. Okay, so you put UVC, UAC. That's an umbilical thing. It's in the belly button. So where is that belly button located? Near the diaper. So it's a high risk for infection. Lucy was even saying in her text, we're keeping these lines in too much. You only keep those lines in so long. And then you try to do a long line or a peripheral line because it's what? It's near a diaper. It's going to get infected. It goes it's a central line straight to the thing. I'm thinking a lot of these babies were probably because they kept the lines in too long and didn't keep an eye on these UACs and UVC, the umbilical things. Again, we would get them out as quick as we could to do it because we knew it was infection. Another thing too is that there was a baby. I'm thinking MRSA. There was a baby that had positive MRSA or was giving two medications for MRSA. And so I'm thinking it might have had a blood culture MRSA. Again, are we washing our hands while we're putting these lines in? And it doesn't even matter if you could be scrubbing your hands. And again, it's like a tray. So for you would put a line in, you would have all your sterile equipment in. And again, so you have a tray and you'd open it up. Well, on the outside of the tray, the equipment room, which was in with the breast milk, and again, with all the sewage, and it was close to room 4, which had sewage thing. It's probably covered with a layer of poo, Enterococcus, E. coli, C. diff. So no matter what, even though you gown and glove, there is no guarantee that that is sterile. So they are entering, not only are they intubating these babies with poo and staph, but they're putting in lines probably that too. And these babies, yeah, you got to have a clean place. So,
Yeah.
and plus they're rinsing mom's breast milk bottles out for that too. they're getting bottles from they're having clear water bottles that they would use to put the feedings for the nose tube. Well, who's to say that outside of that bottle isn't covered with stuff too? So it's an incubator of contagion is what that unit was.
Yeah, very interesting again. So another issue that we're going to discuss now, and viewers will have heard me discuss this several times previously. It's the lack of obstetric history and the way that obstetrics generally works on this unit. So would you like to give me your opinion on that,
Oh
please?
my gosh. So in nursing school, when I was in my pediatric rotation, and I would have to give case studies on babies to my instructor. If I hadn't included the obstetric history on this baby, no, not only did it correlate with what I was seeing in the baby, but what could have correlated, I'd have flunked. Period. Period. Okay? There is no excuse for them to do not to know this obstetric. Now, there is some Twitter stuff about baby A, mom's baby A and B, that no one looked at the obstetric history, and that's probably the thing, and that's another day. But again, they're looking at even Shu Lee noted that on baby B that there was no obstetric history in the medical record that he could see. He had to get it from someplace else. So the doctor's note. So what's really, really important, again, loved my neonatal intensive care unit. Every day, this baby had a head to toe, beautiful note, absolutely gorgeous note. In the start of the note, it was this many weeks, mom with a history of XYZ. Every note, the baby could have been there one day, the baby could have been there 30 days. Every note began with that obstetric history. It didn't matter. So it was just a reminder for that. It reminded the doctors, what is that obstetric history? Because sometimes you're not going to see this for a week or 2 weeks or something like that too. So it's just absolutely unheard of that they didn't. Now there's some question as to, and I'm seeing some things, I don't want to get into it, that there was a reason to hide this, okay? There was a reason. There was a reason. There was a lot of stuff kind of going on, kind of behind the scenes. And again, that is part of a bad hospital where, okay, we're not so good in this department. We're not so good in this department, but we're going to both be, if we're both not so good, we're going to kind of cover for each other, if you get my drift. That's what that's what that group is. And again, you can have a group of nurses like that. You can have a group of doctors like that too. It just I call them the nasties or the lazies or whatever. They congregate and they kind of help each other because I got the goods on you and you got the goods on me. So and again, I can go more in a deep dive later on to that. And just like some of these like twin to twin transfusion. Oh my God. One baby getting too much blood, another baby not getting enough. It's both bad for both of them. In Arrow Park, a baby was born in a toilet.
I mean,
And
that struck me as fairly extraordinary.
okay, now that could happen. Sometimes babies come too quick. But the reason it happened, we don't know. We now know about it. Is at Arrow Park. You're supposed to have a thing you can pull for an emergency. It was all broken. So the mom was sitting there giving birth in the thing, and she couldn't call for anyone. That's why that happened. Let's see. And again, oh, there was a type. It was diabetic moms in there, and again, and again, multiples. Twins are not a singleton, and you don't even treat a multiple like a singleton, because you have to realize that often it is sharing an environment with another human being, getting the all the nutrients enough, having to parse out the nutrients from the thing too. So again, you treat multiples as if they're on, I don't want to say from another planet, but they're not singletons. So, and again, they looked at all these babies as if they were singletons and not multiples. And that's huge, especially for and I've never heard of this. I mean, we never had this. We've never had the mom of baby O and P, one placenta, three umbilical cords. That is, I know I've had mono, I've had a baby with having a share with a placenta with two umbilical cords. And again, some of these babies were sharing, these multiples were sharing the same amniotic sac. That's a big deal. It's a big deal. And that's real important that you know. And even on that note that I tell you that they write every day, they will say, if it's a multiple, did it share one placenta or had its own placenta? Did it have its own amniotic sac? Did it have to share an amniotic sac? All that statistically, they just know. They just know. So,
Very, very, very interesting, Ken. Um, so you raised something with me that I wouldn't even have, it wouldn't have registered with me as even a possibility that would have considered this really. But you're talking about the collecting of specimens. So I know you've got some comments related to this. So can you outline those, please?
well, I did the collecting of specimens. A, you're only as good as the person drawing it. B, you're only as good as the person that's transporting that specimen. C, you're only as good as the person that is doing that thing too. I don't know. And again, another thing too is that I'm looking at babies that should have had lumbar punctures.
Mm.
Okay? And that's part of a septic workup. Now, there is some talk about do you automatically do a lumbar puncture on a kid? Because, you know, meningitis is
Can
big
you
deal.
explain more about what a lumbar puncture is, please?
Okay. All right. A septic workup on a baby's limp. We think it's septic. We're gonna, first of all, first thing we have to do is that blood culture. Chances are, sadly, in most neonates, the blood cultures are negative. Okay, it's just a part of it. Second of all, you may collect some urine on the baby if you can through a catheter. Okay. Third thing you do is that it's a spinal tap. Okay, you have to put the baby on the side. You have to draw a little bit of the fluid that's going from the brain into the spinal thing, because meningitis is a huge sepsis thing in neonates. So the question is that sometimes they have to wait a little bit to do that lumbar puncture because you know you got to put the baby on the side and you don't want the baby doing all this stuff, but you really want to do it. And a lot of these babies should have had that done. And I'm quite and Lucy was questioning on baby D, was that lumbar puncture done? So it's real important. Now, a lot of these cultures now you have to wait a couple of days to get, you know, the 3 days to get the results back. But on a lumbar puncture, yeah, you'd have to wait for that culture for that bacteria. But what's really neat is when the fluid comes out and they collect, it's like clear fluid. It is the most beautiful, clear, crystal clear, diamond looking fluid. So if you even have a hint of anything, you know automatically that is meningitis. And a lot of these, and meningitis is huge. Again, it's huge. It's children. Children are susceptible to it, but especially neonates are susceptible to it. So, and again, what I found really disturbing in the trial was like Ben Myers would say, "Well, why wasn't the LP done?" Well, the baby wasn't stable enough. But yet, in the in the same testimony, the same person who says, "Well, this was a stable baby." Again, Ben Myers was asking very good questions.
Mm.
So they're saying, oh, the baby wasn't stable enough, but yet it's a stable baby. No, again, some of these, not maybe not all. And again, and that's an art to it, and I'm not a neonatologist, and not 100% need them, but a lot of these babies probably should have been checked. And especially now that I'm seeing that Brewery himself noted after baby D died that we got to add to the formulary a special cephalosporin antibiotic that is known to be you give. That's the number one you give for meningitis. You give it for other things too, but it's the known. If your baby had meningitis, that's what you're going to get, and stuff like that too. And then I'm seeing unindicted babies that had it too, and I'm seeing baby C. Now, oh, I saw something recently on baby C. I have to kind of look more. It got that medication, the meningitis medication, but it got another one, that real powerful one used vancomycin. And it says, no, don't give it per thing. And I'm like, I'm trying to figure out why baby C, why they only gave this one, but they intended to give this one and decided at the last minute not to do that. Again, I have to do some more deep dive into that one. And thank you, Lady Thurl. You're giving me all the information I need.
Yeah.
So,
So you've mentioned to me these two issues, lumbar puncture and meningitis in the case
yeah.
of that child D. Um, Can you expand on that maybe briefly?
Okay, just what happened to Child D? Do you want me to
Yeah.
get into? Okay,
Yeah, well, in what way the lumbar puncture and meningitis particularly relevant with
oh,
child D?
okay. Meningitis is known, even in adults. You get meningitis, you have a high chance of getting just massively septic. That is, and that baby was massively septic. It was to the point where it went into it doesn't say in Thirlwall, but Michael McConville believes it went into something called DIC. So again, you really got to be on top of anything, even if the baby is asymptomatic. You always have to think, okay, something's not right. Could it be meningitis? That always has to be in the back of your mind. So this baby went in again. It causes what happens is in babies there's kind of two parts to your immune system. There's the part that recognizes something and works hard and throws atom bombs or grenades and stuff to it to take care of it. Those are poisons. But there's a part of the immune system too that says, oh no, you can only throw a grenade, not an atom bomb. The problem with a lot of these babies and neonates is that this part that says, I have the capability of doing those poisons and killing that thing is well developed. This is not. So what happens is, and especially with that DIC, that baby was so septic that it goes into this crazy mode. And again, that was the adult patient. I remember I saw that died. And that's why baby D is kind of special to me. It causes your body to go so crazy that you clot real bad. Then you use up all the clots and then you bleed. Then you clot, then you bleed, then you clot. The clotting part, the pain part, that baby had to be in massive pain. Plus, all those crazy rashes, that's like classic meningitis and or severe sepsis rash. It's not an air embolism. And Lucy was describing it too to her friend too, and she was saying, just by the look of the baby, it looked like it was septic. I mean, you can just look at this. Anyone who graduated from nursing school or medical school could look at this and go, yeah, that's a septic rash. It's so basic, so basic.
Yeah. Well, I mean, it's interesting to hear this because it seems like a lot of basic things were missed. But it, but we're gonna go over a couple of other issues with child D. But
Okay.
before we do that, I want to tell you something. So you mentioned Colin Morley a few times in this interview, and so people may be aware that in court, Dr. Evans dismissed the idea that pneumonia was significant in child D. He said, oh, the child had pneumonia but didn't collapse or didn't deteriorate due to pneumonia. And Colin Morley simply said to me, well, he just simply can't say that. He just has no basis to say that whatsoever. But
Absolutely.
so that's a good starting point with child D. But I know you want to talk about antibiotics, the administration of antibiotics or lack of administration.
Lack of, and I think I've kind of hit in the thing. Again, they didn't have a set formulary of okay, or they didn't want to go past the what we would call the penicillin gentamicin. That is, and that's the feeling I'm getting. I don't have 100% proof, but again, my chart I'm trained to look at what is not there versus what is there. That is the penicillin and gentamicin you give for moms could have in her body and gave it to the baby, group B strep or E. coli. They don't seem to want to think past that. They seem to think in the notes that, well, the baby's on antibiotics. It's extremely important that you have an antibiotic isn't just an antibiotic. You have to you have to fit the antibiotic to what you think the bacteria is. If right now that baby is on ampicillin and gentamicin and showing some signs of thing, you have to think they're not working. Okay, they're not working. Let's go to our what we would call our second line antibiotics. And the second line antibiotics would usually be what would cover meningitis or what would cover something like a certain staff things. You have to think outside the box. You also have to think, you have to time the antibiotic to the day of the baby. So those first few days, it's usually the gentamicin and ampicillin. Those first kind of three-ish days, okay? They're thinking this baby's sepsis thing is coming just from mom. They don't realize that again, this mom was the dirt's everywhere here, but B, the mom was in the hospital a long time. It may not be that. So if the baby gets septic after that kind of that three-ish days, you have to automatically think that's just like this. It's coming from the hospital. It is the Pseudomonas. It is, and again, there's so many different E. coli, Enterococcus, E. coli, Enterococcus, poo. MRSA is in a lot of hospital waste stuff too. You have to think like that too. And I guess I'm not, it just seems like they were thinking, well, antibiotics is antibiotics. I don't think they understand infectious disease. And where is the infectious disease doctor in all this? And where is pharmacy in all this too? Another thing is that we had doctor would have ordered antibiotics. The pharmacist is charting in that chart going on those on all of our people with things. This is the correct antibiotic, this is the correct dose, because a lot of these antibiotics also can blow your kidney out or have some just profound after effects. And also, if you culture certain things, that's an automatic red light, in my opinion, and it should have been. I'm assuming it's got to be in there. Infectious disease team. They are just, where are these guys? I mean, and they would come in and again, um, now granted, if we had, I don't, and again, in my unit, I only remember one time where there was a baby that was on a long-term second antibiotic, second line antibiotic. And again, who knows where the bug came from, but only one in 10 years. And there could have been more. But again, I know I would have heard it through the grapevine. We heard all these babies. And then later on, I am seeing I want to say not in the very beginning, but later on, I'm seeing amphotericin used. That's for yeast. I'm seeing teicoplanin used. I'm seeing the combinations of this and that. So they damn well knew that this was not Group B strep or E. coli, which is mommy thing. Absolutely. And I'm seeing it more on the unindicted babies than I am seeing the indicted babies too.
Yeah, yeah. So in the case of Child D, there's this in significant, I mean, it's generous to describe as significant, but significant delay in administering antibiotics. And I know a friend of mine is very critical of that, extremely critical. So it seems to be an avoidable death, certainly.
Oh my God. Oh
Yeah.
my God. Do you know that was the only term baby out of all of them? That was the only full term. Okay. Oh my God. Um, they would own not only the hospital, if this was America, but the hospital system. A lot of our hospitals are kind of joined in the whole entire system where they would own. I mean, we're talking millions and millions of dollars.
Mm.
And mom, okay, your waters break. Okay, it happens. Waters break, and sometimes the water breaks before you go into labor. Okay, that's a natural occurrence. Mom
Mm.
comes in, she's like 36, 37 weeks, and they send them, then they're going to send her home, and then okay, come back a little bit. So she goes home for a while, and she stays home for a while, and I'm not sure how long. Again, but she comes back. Now, thing is that it used to be 18 to 24 hours is when you start getting nervous as to when the waters have broken, okay? It's not automatically that you know it's sepsis, but it's red light, red light, red light, okay? Now, on that up, and this is where I'm kind of get to the obstetricians and the midwives here too. And again, I know there's not enough midwives, so maybe they were just too busy, but so when she comes back the second time, like it's been a long time, I need this. And they're keeping her in the waiting room for a long time too before she gets in. So they have a whiteboard. And on that whiteboard, it says the name of the mom, how many babies, what's the gestation and stuff. And on that whiteboard is the time the water breaks. So everyone in that unit can see when those water broke. They left that woman and she had to beg beg for a C-section. 60 hours. Now, granted, the research says 18 to 24. Had they given her initially oral erythromycin and maybe some ampicillin, maybe some gentamicin too, IV, right prior to, but we would not be talking this. This baby was in the womb infected, and they think it was probably, well, Brewery seems to think it was group B strep, but I am doubting because the severe meningitis. I'm thinking mom may have caught a nosocomial too. It might have been both. Again, oh, I'm so upset. That's the one that upsets me more that I can't even think. So, okay, so they didn't even bother with the antibiotics. Then the baby's born. Now it's a C-section. It's an emergency C-section. The mother had to demand it. Otherwise, they would have let her set for another day or two. So 60 hours here. The baby is born, and it immediately goes limp with 12 minutes in the dad's arm. Sandy Bowen said it was due to dad doing it. And also, I disagree with those APGARs. The APGARs looked high. No, no, no. Those were not good APGARs at all. This baby did not have those APGARs. Then they take the mom back and they take her back and just back in postpartum, whatever the post-delivery thing is, and she's feeding this baby and it's limp, and it's the first time mom, too, and they had two pediatricians come back. Finally, the second one comes back and goes, oh my God, this is 4 hours later. Then they rush that baby in, and again, we're talking 4 hours of this. And again, the baby already had a pneumonia. The infectious disease, the infectious process started too. The inflammatory response started well before this baby was born. And just an FYI, there's an unindicted baby too that's got congenital pneumonia too that I
Yeah,
found.
absolutely. Yeah.
So it's just heartbreaking. They didn't even bother to give this baby an LP. I don't even know if it was in, I know eventually it went into room one, but I'm even wondering if it might not have even been in, it might have initially gone to room one and gone gone to room two. I have to figure that out. So it may not even been as monitored. Plus, again, babies crash. And with sepsis, if I see it with adults, I've seen it with adults, like 1 minute they're fine and next minute it's like this. You can imagine what it does for a neonate. There's no such thing as, I don't care what Dewey said, you know. So it's heartbreaking. That's the heartbreaking one that seems to bother me the most.
Yeah. I know. I mean, I've got a friend who also was a nurse, and she says the same, really, essentially.
It was a
Um,
term baby. I mean, if all, yeah, yeah, the other ones now, most of these other ones probably could have, but the ones that survived, there's like four of them. I don't know the names. They're profoundly disabled children. Now, one of them they blamed on Lucy because they said was during one of her attacks, it didn't get brain damage. It got severe cerebral palsy. No, no, no.
yeah, absolutely. So, lastly, we're going to look at the conclusions of the expert panel. So, do you have these on the screen? I can put these on the screen for you.
Okay. Okay.
Let's do that. Hold on. So we'll start. I just got to organize this. Just bear with me.
That's okay.
Uh, Hold on. Here we go. There we go.
Okay.
So now we can see the 25 issues that were recognized by the expert panel. So you're going to give some comments on each of those 25 issues, beginning with number one, the medical histories were incomplete.
Uh, Shuli noticed it too. Okay. And I'm noticing it too. It's what is important is just important what is omitted as what is said. There is stuff in there. I won't go into it now, but I can guarantee you I'm doing some more deep dives. Hidden things. There's things they're not saying about these babies, particularly, and they're not, again, that's another thing with doctors. They will chart only so much, but they won't chart the bad stuff, okay? So, and Shuli even mentioned it, I think it might have been either A or B, or one of the other babies that something is missing here. So failure to consider obstetric
Yeah.
history, we went
So
through that.
disregard for surveillance warnings. about infectious bacterial colonization.
Oh my God, that's huge. Okay. The reason that is huge is that a lot of these babies went to Alderhay or Liverpool. They have really high level intensive cares where and it doesn't matter if it's a neonatal and high level neonatal intensive care or high level adult intensive care. There are just certain nasty bugs that are in there. And and you want to make sure that you keep those nasty bugs there. I mean, it's part of it. You can have the best of the hospitals and still have it. So that's where the Stenotrophus, Stenomonas maltophilia come on. In fact, I didn't even know what that was. My nursing friends didn't know what it was. We looked it up. It's one of those really nasty things that you have in a high teaching, high level ICU that has a lot of immunosuppressed patients that are on ventilators. So, and again, a lot of those things are coming in. So,
Yeah, absolutely. So I think with regards to misdiagnosis of diseases, that should be very evident to anyone that can
well,
read.
actually, I have a comment on that if you don't mind.
But I'd love for you to comment on it as well.
Okay. They kept saying baby C is neck, baby C is neck, necrotizing enterocolitis. What they weren't looking, because the bowels were dilated, meaning there was gas in the bowels, okay? And it wasn't showing, and Alderhay was correct in that, is that it wasn't there's a certain pattern it should show. No one is realizing the reason the bowel is dilated is because the baby, and it happens in adults and in babies, if you are so septic, your body goes into crisis mode. It just stops feeding or stops dealing with the intestines because you can live without your intestines for a while, but you can't live without your heart. So the bowels stop. They stop working. Stop getting the blood flow they need. So obviously do it. And I think and I believe Shulise called it ileus. We call it ileus here. It's just a stopping of the bowels. They kept thinking this is neck when it was really baby's so septic, their bowels stop working,
Yeah,
which is really sad.
yes, absolutely. So again, five is quite well known. It's very
Yeah.
clear that some of these infants should have been in tertiary units. I don't know if you have anything to add to that. I mean,
Yeah.
this is fairly well established.
Yeah.
Six, unsafe delays in diagnosis and treatment of acutely ill patients.
Oh, I again, they didn't know what they were looking at. They no here. Okay. Again, my neonatologists, what they were really good. What they I could see in their charting, they were the best of the best. Gosh, I wish my adult ones were this good. They always, you could see in their charting, they were thinking 3 days ahead. No, they were thinking 3 hours ahead, 3 days ahead, 3 weeks ahead, 3 months ahead. So they're just thinking ahead while they're looking at the baby. And again, 3 hours, 3 days, 3 weeks, 3 months. So they anticipated everything ahead of time. So they never had to really put out a fire. The only fires they really had to put out were the ones, baby's born at delivery, that's an emergency situation.
Yeah, absolutely. So we've discussed intubation, number seven,
Mhm.
but also resuscitation. So I will say a little bit about this first. So Colin Morley again has told me that firstly he said the skills obviously just went up to it, but he also said to me it's a lot more difficult than was presented in the court case, and that you need the experience of doing it. So I don't know if you have anything to add to that.
No, and agreed. And again, my guys were neonatologists. They did it all the time. And they also didn't just stay in my thing, which was a little bit, I wouldn't call it boring, but it was little meat and potatoes kind of things. They would go to the children's hospital, work in there, come back. So they would up constantly transferring back and forth to some degree to make sure that they were always up to date and always with their intubation. I'm sure there were some issues maybe with some of these babies, and especially with the micro ones. I'm sure the ones at deliveries that they had to just, I mean, literally throw off to the children's hospital. But I don't remember hearing through the grapevine, and I know I would have if it took several times to do that at all. These guys were great.
Yeah, yeah, absolutely. So number eight, I think, is something that you'll want to speak about, which is just poor supervision of junior doctors in procedures.
I, Part of me
This
is thinking
this
that,
comes back to the ward round as well, doesn't it? Don't you think?
oh, yeah, no, I don't believe. Okay, here's my opinion. Ward runs were done once a week, not twice.
Right.
And the reason I'm thinking that is that, first of all those weekend babies were sick. Second of all, thing here, like in America, we kind of do things halfway on the weekend. All right. Hospitals somewhat closed down. I'm sure they do there too. It's just kind of who wants to work the weekend?
Mm.
Okay. Um, Another thing is that one of the new things that was just Jabe sent out, there was some new Thurwell that was just put out. One of the doctors there that was a junior in his Thurwell thing said, oh, they only did board rounds once a week. So I think it was they
Okay.
did, and I do think that Wednesday probably was a good ward round. I don't deny that.
Mm.
But again, I'm thinking the weekend one was like, I'll just talk to him.
Yeah. Yeah.
Yeah. And then the
So
junior doctors, again, I have this feeling that the consultants were so nervous taking care of these babies. They just wanted to focus on the pediatric ward. It was just kind of this, okay, I'll just get through this shift,
yeah.
or, kind of a thing. And just let the junior doctors and the registrars, it was so wrong.
It's- so I think there's a lot of evidence of poor basic skills with
Oh,
procedure.
yeah.
Mentioning insertion of chest tubes here.
Oh, yes. Baby H. When I told my nurse friends here, they were just absolutely apoplectic. Okay, there's the thing called butterfly needles. I don't know if you know what those are, the little steel
Yeah.
things. Sometimes if you need a blood draw, they'll do it.
Yeah.
They freaking ran out of chest tubes.
Mm.
Okay. They stuck steel needles into that baby and kept it in for hours. That baby probably got repunctured. A steel needle. Can you imagine the pain on that? You can stick a steel needle into a baby if you need like what they would call a tension pneumothorax. I'm gonna stick that needle in, it's gonna come out, and then I'm gonna take that needle right out. They left it in. Another thing is that, and Granny, I'm a grandma, 65-year-old Jenny in her basement in America knows you inserted chest tube, it's the fourth, fifth intercostal space. Jerem didn't know that. And here I know it. So, and again, with baby H, well, and he said in his testimony, well, the baby wasn't harmed. Well, it's real important where you put that chest tube because you could hit something. You could hit a liver or something like that. And again, he was not up to he was not up to snuff on his skills,
Yeah.
even knowledge.
Mm.
I even wondered if he even kept up just for the book reading and stuff like that too. That's what I'm questioning. Him and Gibbs, I think, were probably the worst.
Yeah. Yeah. So the next one we've kind of covered because of ventilation. The next one is, again, I think we touched on this, but maybe you could add something. Poor management of neonatal conditions such as hypoglycemia.
Yeah, I didn't. It's really kind of no big deal to deal with a baby with hypoglycemia to some degree if you know what you're doing. Okay, and again, most of our babies that got hypoglycemic get on the floor. Okay, all of a sudden the that nurse that's on the floor, we don't call them midwives, but let's just say the midwife on the floor brings that baby, literally would carry that baby in. Again, they always had an open cot for these kind of emergency situations. Like, okay, baby's jittery, they could get a line in or they get some sugar down the baby. It was kind of a no big deal thing. Um, and again, I don't understand. Again, they're saying Lucy did insulin and this and that. I just think they weren't doing it. And I even wonder and there is certain protocols, no matter the baby's healthy as can be, term, neonate. At this hour you draw the blood glucose. This hour you do. You automatically check. And I don't even know if they even had, again, they didn't have protocols for antibiotics. I'm sure they didn't have protocols for something as basic as monitoring a sugar on a baby. Oh, and it wasn't the glucose monitor and not working, and along with the
Yeah.
ABG monitor too,
Yeah.
the blood
Yeah.
gas.
Whereas,
Okay,
yeah.
that could have been the reason.
Yeah.
Yeah.
So the next one very much feeds into resuscitation, of course, lack of knowledge about commonly used equipment such as the neopuff and capnograph. I don't know if you want to expand on that at all.
Okay. Well, first of all, Shuli he eviscerated Ravi. He absolutely eviscerated Ravi with baby K. And again, Ravi should have known that Neopuff, okay, that baby was so preemie that you needed something more than a neopuff. Again, you would use that on most babies because you don't want to blow their lungs out. But this baby didn't really have an expanded. Ravi should have known that too. Also, he should have known the tube was too small, so it was leaking out. So the capnograph is kind of around the end here, and it's picking up the carbon dioxide, and that's telling you oxygen's coming in, carbon dioxide's coming out. So it couldn't have picked it up because it was just expanding on this. And there's also some question on another baby, which I won't do, and I need to do some deep dive, is that he may have, I think, total conjecture, he may have intubated a baby and forgot to check the capnograph on that baby too that died too, but that's for another day.
Hmm.
So I'm see Ravi is like, oh my gosh, he doesn't know his tubes. He just doesn't know his tubes.
Yes. So 13, I think we've kind of covered because it's
Mm.
poor intubation. I think we've established that they could have done that quite a bit better. So I think 14 is really interesting. I mean that stood out for me as mainly because I can appreciate it probably better than some of the more technical medical stuff. But it's quite obvious because I'd read so much of Thirlwell when I received this document for the first time, and it's just very obvious that they had huge team working and trust issues on this unit. You know, there was a fissure running right through the unit between the nursing team and the doctors. Um,
I'm gonna to some degree disagree with you.
okay, you
Okay.
tell me what you think then.
Okay. I don't think it was a man versus woman, doctors versus nurse. Phone it in, lazy. Work hard, Lucy. You could tell where those Lucy's
Right.
friends in. There were some nurses there that, and I won't, they will go unnamed. I'm not, and I'm seeing their trial statements and what they've
Mm.
done too, and I can tell the things. They weren't giving it what they should have been giving it to. And I wondered, some of them were a little bit of the friends of some of these consultants too. Now, granted, Brewery and Jerram, hands down, were the worst. Poor management skills, poor executive skills. People in this poor, I feel sorry for Lucy. And again, I had a really good discussion with one of my best friends, nurses too. It was like it was like she was going into, it was like a World War One situation. She was a soldier in the trenches here. The officers didn't care. They don't give you good equipment. No one really cares. You're only as good as that person right next to you to save your life. And Lucy had some outstanding, and some of those nurses were wonderful, but not all of them were. So I'm thinking it's more of a dynamic, and same dynamic you get in any factory, any
Yeah.
Starbucks, anything. And there is that people that really work, and they usually like do a lot of the work of that person, the lazies too. And that lazy person resents that person who's putting in that effort, resents that person. It's obviously they feel they're showing them up. So again, I'm not seeing the best of teamwork even in the nursing thing, except for Lucy and her friends. And that's another thing too, is that I think neonatal nurses are a lot different than orthopedic nurses or cardiology nurses or adult nurses or whatever. Every baby is their baby, okay? And I know Lucy was terrified because these babies can't talk. They can't, like an adult, can't scream or say, I need help. She knew, I'll give you examples later, where they weren't being watched not only by not the consultants, but maybe not by the best of nurses too. And not talking unskilled, maybe some of them that were phoning it in. And she felt like she had to go. She felt that's what makes a wonderful nurse. She was felt obligated to go and do this and help. So it's again, the teamwork is also in the nursing, in the doctors, management. I'm not having a good thing, and I'm not having good thoughts about the executives. But again, I'll say those. I'll say that for until I have more I've done more research. This is just being a nurse. All units work to some degree the same way.
Yes,
Dynamic.
of course. So the next one is listed here as number one, but we'll call it 15.
Yeah.
Inadequate numbers of appropriately trained personnel. So
Oh yeah.
one thing, before you just answer the question, we obviously don't know how much people were trained on the unit.
Mhm,
These
mhm.
people obviously must have done some research. They must have indication of that. We don't have a full picture of this. Of course, we know they don't have a neonatologist, just to give one example.
Yeah.
But maybe you could talk a little bit about how important it is to have appropriately trained personnel.
Oh my gosh. They were calling, and I'm not trying to denigrate them at all or anything like that. Nursery nurses, nurses. They're
Mm,
not.
mm,
Think of them as a nurse's aide. They were there to just and and they're absolutely important. I'm not trying to denigrate them, but the babies that are almost close to discharge, they're there to feed them and clean them and stuff like that. Some of these, and I'm trying to find examples. Some of these poor nurses were expected to watch some of these higher level babies while the nurse went out for a break. And again, another reason why Lucy might have gone in and helped. Again, was it they got rid of Michele Worden? They had no master's level nursing there. Michele Worden there. They had we know Lucy and just one other that was ICU trained. That's
mm.
absolutely unheard of. Not to have you're in an ICU. Now, granted,
So,
some
so
of those,
you don't know this, but
yeah,
they because Lucy had worked in a tertiary unit, they put her on a bit of a pedestal. This is part of the reason why she's dealing with a lot of the more ill babies. I mean,
right,
that's
right,
partly a reflection on her dedication and how she was regarded, but it's also because she's been on a tertiary unit and others haven't.
yeah. No, but she trained at Liverpool and stuff like that too.
Mm.
It's like an advanced certification, and it's real important. She saw all that. She saw the worst of the worst at Liverpool. I would imagine the only other place that baby would go would be Great Ormond Street. I mean, and that would be for thing. But otherwise, that I would imagine it would be extreme rare for them to have to transfer a baby to Great Ormond Street in London. But again, yeah, she saw it all, and she was also trained and supervised and stuff too. So again, and some of these nurses, but okay, some of these nurses still, even though they weren't trained, and I don't have, and again, I don't have, I'm looking here from America. They should have, again, I'm thinking Ray the radiologist is a perfect example. Okay, maybe I'm not trained in this. Maybe I don't know this. I am going to do the research to do this. So maybe they're one of or two of them could have kind of stepped up. Maybe they couldn't have sent them yet to Liverpool, but they could have to some degree, like Ray did, on his own time, done that. You're in this crisis situation. That's what we're taught in nursing school too, is that, okay, you have this knowledge, but you don't have the excuse to some degree not to have that knowledge. You have to keep striving. You have to keep doing it. You know, you are you're the last stronghold. You know, if the doctor screws up, well, if you screw up too, you're the last resort to some degree. So were some of these, and again, I don't have actual knowledge, and I'm looking at some of the witness statements, and I'm trying to figure out what level they were. Where they just when they clocked out, they clocked out. They weren't thinking, or trying to improve them some degree until they could reach that level and
Yeah,
stuff.
yeah. So the next three, lack of training for assigned nursing roles is obviously very much tied into that. I will just comment on these two because we know. I mean,
Yeah.
there's nothing to add really. We know they had inadequate
Yeah.
staffing, and we know they had really testing acuity, and they were overloaded. Just to mention briefly with regard to the staffing, they're completely reliant on part-time staff, with agency staff and bank staff, as they're referred to. I don't know if they use that phrase in America, but
Yeah, yeah.
yeah,
PRNs, per diems, and agency. Yeah,
yeah,
yeah. I mean, they're good. I mean, they would be fine for the
yeah,
what we would call the feeder growers. The babies just need they're just need to- they just need to eat, grow a little bit, and feed a little better. They're fine perfectly. But again, oh God, were any of these? Oh, I hope they weren't in the ICU or anything like that. So, unless they were specifically ICU trained, there are some agency nurses that are phenomenal ICU nurses here in America. So
mm,
again, you don't know. You really don't know and
mm,
stuff. But they would have just been there for the shift. They wouldn't have known the babies, unless they're there for several shifts, or they're there a lot,
Mm.
they wouldn't have known the individual babies. It would have just been, okay, you're just here for this 8 hours. And some of them probably were okay and stuff, but you don't know. You don't know. And I don't think anything, even CQC noticed it didn't meet whatever the standards are for the regulations for the
It's called
patient evaluation.
BAPM
Yeah.
standards, so it didn't meet them. Um, so the next one again is undeniable, poor plumbing and drainage. I mean, I don't think anyone could possibly disagree with that, resulting in need for intensive cleaning. So, I mean, this is almost a banal question to ask you. We've heard from many people previously, and it's pretty clear you don't need to have any medical knowledge, but you've obviously heard about the the sewage situation, the problem they've got with bacteria on the unit, the problem they've got with sepsis, Stenotrophomonas, Pseudomonas. I mean, from your perspective, how bad is the picture that
Oh
is
my
being?
God. Out of 1 to 10, a 15 or 20. It just I cannot fathom this. Now, granted, even in my bad hospital, the hospital was built in the 70s. Even the good hospital, the hospital built in the 70s, you're going to have some plumbing things. I've never heard of having a plumbing thing in a patient area that they don't immediately close down, or that whole massive area. And not only do they not close it down, but they'll kind of build almost a containment wall over it to some degree too. Because they're old buildings, but absolutely unheard of that they allow this to happen. And again, the executives, mm, that's
Mm.
where I'm having some real problems with. Nursing can only do so much. And sad thing in the trial, I saw some of the things with the plumber, um, with Johnson. He was saying, with the plumber, well, the plumbing, it's okay. There was sewage. There was a massive sewage in the labor ward that was right next to, only a wall separated that from the unit one. And he goes, well, it's okay because it was in that room next to it. So he downplayed the plumber. It was just sad.
Yeah, I mean, as well, we've seen how cramped the unit is. It's not as
Yeah.
if it was a mile away. It's like they're right next to each other.
Yeah.
So it's you know that that's what he's there as the prosecution. He's there to try and downplay these things, I suppose.
Yeah.
But yeah, it's pretty disappointing. So let's talk about or no, actually, I want to ask you a follow-up question.
Uh-huh.
Yeah, I meant to ask you a follow-up question. So I think we can talk about the executives with regard to this issue.
Yeah.
So, because what I've always wondered is, to what extent are the executives kept in the loop about this, about the sewage, about the drainage issues, about these things. I mean, it's obvious. I mean, even Dewi Evans said that the unit's got to be closed down. It's obvious because you don't even want, like, if I had sewage running through my house, obviously, you want it sorted out immediately and it wouldn't be livable. So, to what extent should the executive have known about this, and to
Oh,
what extent,
absolutely. And
to
they
what
will use
extent
the
can they be?
excuse. They will use the excuse, well, no one told me. My comeback line is, it was your job to know, period.
Hmm.
It was your job to know. And it's one of the reasons I say that they are stuck in their offices. And they used to not be there. And they think they're too good to get their hands dirty or smell the smell of a hospital. They feel themselves, they feel that they're above that. That's for the peasants. They're the lord of the manor, if you get my drift.
Yeah.
It was their job to know. Now, another thing is that they were spending a lot of money during this time or right before at the Countess of Chester, upgrading they wanted to become a stroke center. I don't know if you knew this and how important that is. It's a big deal. Be stroke certified. So in order to be stroke certified here in America, it's the same way over in the UK. You got to have updated OR things just in case you have a bleed to the brain, A&E, radiology, and intensive care. They were spending all this money on that to get, and being stroke certified is a feather in your cap.
Hmm.
It's here in America. It's like they advertise that they're stroke certified. So and again, they were anticipating they were going to this media thing. They had all that money for that, and they were letting this go in the unit. No, no, no. It was their job to know. And another sad thing, and it happens here in America, is that often maternity and pediatrics is usually the last on the list. Because guess what? It doesn't make anything sexy in the media. Children don't vote. Um, you know, you want your grandma to be, or you want to be able, if you're having a stroke, go to the thing. You're not really thinking about kids so much. So again, there was money there.
Mm. Yeah, that's great. So let's look at the poor environmental temperature control in the facility. Now, again, obviously, we can't corroborate this
Oh, I
because,
can, I can, I can tell you what it is.
okay, well, let's talk about this then.
I can tell you what this is. Baby N is a good example, another baby too. Those babies were cold. They
Mm.
were cold in the delivery room. Even Brewery noticed delayed cord clamping. Okay. And a full-term baby, stuff like that too. You delay the cord clamp, they're gonna bond with the mom. May not, you don't want to cut the cord quick and stuff like that. Well, you got a little baby preemie. You got to get that under that radiant warmer. You got to get it under the plastic. You got to get it under this. You get a baby cold, you're gonna kill it. It will die. Cold, one of the most important things. But okay, respiration first, temperature second. Okay, and they set the line in motion for the sepsis right there by letting those babies get cold. Baby N is a beautiful example. Michael McConville did a beautiful pot in one of his podcasts, explained that this baby was even cold entering the NICU, cold in the NICU. And I'm going to do another deep dive at some of these temperatures too. Again, they were allowing the babies to get cold in the NICU. And even Lucy was saying, um, we have broken incubators here.
Mm.
So that's where it's coming from.
Mm.
It's
Yeah.
the damn equipment. And again, how up to date is everyone? Again, are they also up to date in the obstetric part dealing with? They're used to dealing with a certain size baby. Okay, did they know that they have to wrap these babies in a there's kind of a plasticky thing and or get it under the radiant warmer or really check those temperatures?
Mm.
They may not have known it too. And also
Mm.
the obstetrician was delaying the handoff to get under that radiant warmer to the person, keeping that baby close to the mom. Well, okay, in a non-micro preemie or a preemie baby, a mom's temperature is fine. That's wonderful. It's perfect. But not for a preemie baby that's got a skin that doesn't have really, well, got skin in name only. So you can imagine these babies just get, one of the best ways to kill a baby is to let it get cold. And that's what they were doing.
Yeah. I mean, I find that one really hard to understand, but I mean, you just think maybe what you're saying there, maybe it's just lack of knowledge, but you would still think that's so fundamental. It's so fundamental. It's to me as a non-healthcare worker,
It's
like the
lack of
least.
knowledge and it's phoning it in. It's like, well, the other person doesn't care. The other person doesn't put in the effort, or, I'm just clocking off of it. And you do have those days. And I do have I hate to say this, and that I've had those periods too where I kind of clocked it in too. And it's part of you're in nursing for 40 years. And anyone who says that they're not in healthcare for this length of time and doesn't admit to having those periods where you were kind of clocking it in, not giving it your best, is lying. But you have to, that's where you need the Michele Worden. You would look at that person or the Lucy, you know, boy, they're doing good, and I'm not doing good. I'm going to try to be like that person. Self-reflect. And
Yeah.
again, there's a crisis situation. No, the boss isn't telling me what to do this, but I'm at home for an hour. You can watch, everyone watches Dancing with Stars. You spend 15 minutes on the internet just trying to self-educate yourself. That's what Ray the radiologist did. He self-educated himself.
Yeah. Yeah.
And nurses can do that too. There is no excuse. Again, in nursing school, that is stressed. Okay, you only know so much here. It is your obligation to go. And now, granted, yeah, there are some situations where you put in it, no, it's wrong. But at least give it a shot. And if you know it's a crisis situation, it's not like a factory job. You are ethically bound to at least try to better yourself on your own time. At least give something.
Yeah, absolutely. Fair comment. So regarding the difficulty in finding a doctor when need arose, this can't come as a huge surprise
Oh, no.
considering everything we've discussed. What I will just briefly cite is that there are at least a couple, and there may be more, cases, situations in the court case in which there was a massive delay in locating a doctor at a critical juncture, and there were delays that were the best spin you could possibly put on them is that they were regrettable. They could have been fatal potentially. So I don't know if you've got anything to add to that from your specific.
Oh, yeah. I have a few examples of that. First of all, baby A and B. This was an emergency C-section. This mom was had his in her 20s had a history of stroke, APS, the whole bit. She's put under general anesthesia, okay? That's a big deal because that baby can come out limp because of the general anesthesia. They that it was must have been utter chaos when these kids came out, and there was it a 1 and 2 year post medical school, and then a nurse to deal with this situation. They crash called Dr. Salati. Dr. Salati never showed up. Okay, he testified at Thurwell he did, and there's documentation that he didn't show up. There's also another document that's just sad too. I have to question too that some of these consultants or doctors, and we all nurses have this too, where you have a doctor with an attitude. You try to call them and you think you're asking them to, give you a pint of blood. And it's a perfectly thing. And there's a certain nastiness to them. So you really are almost hesitant to call too. Another thing is that, oh, it just broke my heart this week when I saw this. So they were in agreement in this neonatal thing. They could call if they were in a situation at Countess of Chester. They could call Liverpool like, help. Just give me some advice over the phone. And in this instance, I will give the Countess of Chester thing, and it was Dr. B. She called them. My God, a C. Baby C had to go on dobutamine and dopamine, massive intensive care medication. It was so septic. I mean, it had probably had no blood pressure. No wonder it stopped breathing. Liverpool, Dr. Yoxel didn't call him back for 7 hours. Okay, I can see an hour, 45 minutes, and this was a bad case. And they had called Alder earlier to look at it to see because they had a belly issue. Now Alder is a children's hospital. It did not have a medical intensive care unit, it had a surgical. So it only dealt with the surgical. Liverpool dealt with the medical. Perfectly reasonable situation. But they told them, and this baby had, again, misdiagnosis. They thought it was neck, and it was really a septic ileus. And they're saying, Countess of Chester doing the right thing, saying there's dilated bowels here. And Alder Hayes saying, you know what? Last time you sent baby I, this was baby I, with these both things. You thought it was neck and it wasn't. We sent it back. Well, and so we're just going to sit on it. This baby, there was an acute abdomen situation. It may not have been neck, but when I say acute abdomen, there isn't a human being in the medical field that doesn't go, oh my God. Okay, so it was acute, and then so Aldehyde was saying, sit on it for a day during an acute abdomen situation. We don't think it's neck. You guys were wrong the last time. That's kind of the feeling I'm getting and kind of the thing. And then she calls Liverpool and they're saying, yeah, they don't get back to her for 7 hours. And that was Dr. B. So this time Dr. B did everything and she threw dobutamine and dopamine on it correctly. But again, this is not the place you want dobutamine or dopamine. And I won't get into that, but that's a big, big deal.
Hmm. Okay, well that's very
Yeah.
interesting again. So let's just answer this one briefly.
Yeah.
Congestion at medication cabinet preparation trolley.
Yeah, yeah. I mean, well, the medication and the preparation trolleys were in room one. Everyone was going into the Pseudomonas room. And plus and sometimes you do need to get to it. If it's a crash situation, you got to get to it quickly. And there were times, and Lucy put in the Dadex too, they were missing resuscitative drugs or the drugs were expired. Who the heck was checking the crash cart? That's a nursing thing and a pharmacy thing too. So that was both with that.
Yeah. So next one we've discussed sterile preparation, drugs being prepared in the corridor. The next off that is some high-risk infants. I think we just know these all of these things. So
I do know something about Arrow Park, about 10,
yeah, tell
that I
us that.
just found this week. Arrow Park, first of all, look at the CQC, everyone, on 2014 and 2015 and 16. It makes the Countess of Chester Hospital look like the Taj Mahal. Everything except for one thing had horrible thing to it. Another thing is that Arrow Park, and again, Liverpool was supposed to be a 3, Arrow Park was supposed to be a 3. They were supposed to have 2 3-level medical, and Alderhay was the surgical. They did not meet standards, and this was known in the CQC. It was known as early as 2015 that it did not meet standards for the number of cots it was supposed to have by what it's supposed to have. So that there was a shortage of just you couldn't get kids into Arrow Park too. That was a big problem with that. And I just found out that this week. And again, everyone look at the CQC on Arrow Park. It's gut wrenching, gut wrenching.
Yeah, and the last point very much relates to
Yeah,
that. There was delays in transfers of sick infants to
yeah.
high-level facilities. So this occurred partly sometimes due to a lack of action at the Countess of Chester, sometimes due to oversubscription of beds in other hospitals. I think sometimes due to bad decision making. It's just a combination of factors, really.
Perfect start.
Yeah, exactly. So there's not too much we can add to that. This is just known to be the case. It can't possibly be denied. To be fair, even the Countess of Chester recognised in their internal documents that they were not doing a good job of this.
Yeah, yeah.
And
Well, they had to. I mean, they had they had to. I don't think it was. I don't think they voluntarily said it. I think they tried to hide as much as they could.
Mm, yeah,
All of them did. All of them
yeah,
did. There's some other things we can get into about Alderhay had some problems. I can get into things that I found out another about Liverpool too. They were all. They were not. They were phoning it in.
mm,
They were not giving it their all. They knew there was this crisis situation because there was what, 2 level 3s in Wales that only knocked out, and then one maternity thing in Wales too, that there was only midwives they could go. So there was a crisis situation, and it doesn't seem like, besides Lucy and maybe a few of her friends, the only one who was giving it their all was Lucy
yeah,
in this whole thing. I can point out all the characters in this. And again, you're only as strong as your weakest link.
yes, yes, absolutely. So that's all fascinating.
Yeah.
So I think we've spoken for about an hour and 45 minutes now.
Oh, okay.
So there's just one last question that I would like to ask you.
Yeah.
So you've mentioned your friends a few times who are also nurses, and I'm just wondering, as you've been mentioning this, have you discussed the case with them, and if so, what do they think about it?
Well, first of all, it was a good case for me as self-reflection. Instead of
Mm,
saying, "Oh, here in America, we're so much better than you guys so far as the justice and the thing." No. And it was a really good learning lesson for me to be a the radiologist. Think, I think of all the injustices had, and that there,
mm,
we're all thinking. Although we may not have a Lucy Letby in that sense, we were all self-reflecting. Like, oh yeah, I could see that happening.
mm,
Yeah, I could see that happening. And again, what is kind of bothering the nurses and me too, is that this is so obvious that again, we have a micro version of this where a lot of nurses are, we can see how a nurse is going to be blamed. And again, our finances are going bad down here too in the United States. We're going to start seeing nursing blame for bad hospitals too. But again, to just this degree. But also we're also feeling really good that a person like a Colin Morley, Shu Lee, I mean, and the statisticians, I mean, we're talking world renowned, the Royal College of Statistics, that's the world leading statistical thing in the entire world, are just coming, and we're almost humbled the fact that these incredible people are coming to join. But not only that, I'm telling about you people,
Mm.
about this kind of this community, and it just how it's like, I don't want to call us the peasants, but to some degree, we would have been thought of as the peasant class, and they would have been the lords of the manor. And it's like this,
Mm.
you know, everyone's on the same level. So
Mm.
in one way, it's sad, but in the best way, it's really been uplifting
Mm.
to some degree. That just to
Yeah.
see how everyone has just come together in this way, and no one is stratified at all.
No. Um, I mean, that has been the only silver lining for me is that
Yeah.
I met so many amazing people through doing this. And, I was in Manchester and met loads of people, some of whom I'd spoken to online before, some of whom I'd never met before at all. And yeah, it's really inspiring to meet so many great people and to think, you know, I'm sure we're going to get Lucy out of prison eventually. Hopefully, it's going to be sooner rather than later. But I do think that we will persevere and try to have a bigger impact than just overturning this case.
Um,
Because things that
yeah,
need to
I
change.
I agree, and guess we're not hearing about this over in the United States, even though the New Yorker, you'd think with the New Yorker
Mm.
article, we would have, but it's going to be again, it's going to be looked at here in the United States like, oh boy, a lesson to us, and it should be a lesson.
Mm.
And I'm really upset at our nurses, kind of, the top of the line, though your version of your unions and stuff like that, they're silent. They
Mm.
they should be they should be screaming louder than me, because
Mm.
how easily this could happen over here. It is dead silence from them. And I am really upset at my nursing leaders here in America. It shouldn't take a peasant. You know what I mean? A granny in her basement in the middle of America, retired, you know, to do it. It should be us working together. Oh no, no, no. And the sad thing about our nursing leadership here, and the thing is that they base all of their stuff on the political party. And it's a certain political party who they back and a political party they don't. So I'm wondering, I don't know if that is the case with the Lucy situation here too. Has it gone political? Because if this was a
Um,
Lucy Letby thing, it would have gone Democrats versus Republican.
yeah, yeah. It's not overly political yet
Okay.
because I don't know. I'm trying to put this as generously as I possibly can.
Yeah.
Um, Politicians are very reluctant to get involved in anything like this because you know they always they've always got the kind of coward's way out of saying, "Oh, well, it's the court's issue. It's not our issue. So we can't do anything." We're very lucky Sir David Davis has spoken out and
What a
spoken.
wonderful man.
Yeah, yeah, he's a
Wonderful
great
man.
guy. And the thing is, you don't realize he's 77 years old. Like he doesn't look it or act like it, but he's not young. He's nearly 80. And he's still absolutely driven to do good in the world. And I really
Yeah.
hugely respect that, of course.
We have a
Um,
few politicians like David Davis, and just our greatest miscarriage of justice that's really bothering me is occurring in the state of Texas. I don't know if you've heard about the gentleman.
yeah,
We've been
I
trying to
have.
execute him so many times
Yeah,
due to it was a father shaken baby
yes.
syndrome. The politicians are not, the judicial system knows that shaken baby syndrome is a joke. And the what we saw on the autopsy was due to resuscitative. And they said, okay, we agree, but we got an execution date. So, and again, it's the same Innocence Project, the same type of thing that Mark McDonald, and they have a real good handle on it. They've been able to, even last October, they were able to keep this guy out of the execution chamber. But I just have this feeling they're just, it's like, and again, it's just like your appeal judge. Well, she was found guilty, or in
Mhm.
him, he's got an execution date. They just, in our judicial system, they can't see beyond the box
Mhm. Yeah.
here too.
Have you read John Grisham's book that he's written recently?
No, no, and I'm not into
Because
here.
he he
This is,
um
yeah.
he represented that guy.
Oh, I didn't know that.
That's
I'll have to
that's
read
where
it.
I heard about it.
Yeah.
Yeah.
John Grisham's a good guy. He didn't live too far away I used to live in Memphis. And
Mm.
a lot of his, we lived in Memphis for a short period of time. I loved living in Memphis,
Mm.
Tennessee. And he lived in Olive Branch, Mississippi, which is literally just, I drive there. So and a
Okay.
lot of his things a lot of his things are based in a Memphis. A lot of his
Right.
books are based on
Okay.
Memphis and stuff. And just an FYI, the same time I was down there in the 90s, Memphis, Tennessee is in this part of the state. Nashville is in the middle of Tennessee. So Mark McDonald was in the same state I was at the same time. And I
Hmm.
know he would have probably gone and visited Memphis because it's a great town to see. We
Yeah, well,
had to
you would
see the
do,
health
wouldn't you?
stuff. So at some
Infamous.
point, I was in the same city as Mark McDonald.
Well, that's ironic, isn't it?
Yeah.
Yeah, yeah. So that's great. So thank you so much for joining us today and
Oh,
sharing
no,
your
Chris,
knowledge.
thank you. You're helping a fellow nurse. You're giving it you're giving it all. You're not phoning in. So it's me that should be thanking you.
No, no, no. I mean, I obviously
Yeah.
I get a lot of gratitude and I appreciate that. It means a lot.
Yeah.
But I mean, I had to. Once I knew about this, I just
You have to.
had to do something.
Yeah.
And I didn't expect to be here on YouTube. And you know, I was at the meeting the other week, and everyone knew I was. Like people I didn't even think would know I was. And as soon as I spoke to them, like, "Oh, hi, Chris. Love you with all this." It's like, how do you
Well,
even know who I am?
your dog is
So
getting famous too.
even Kiko is famous. Kiko's been
Yeah,
reasonably
Kiko is
well.
famous. Remember, I was the one that made the comment that says when you get world famous and
Yeah.
you're giving your acceptance speeches to all your awards, you got to mention Kiko.
Well, it's typical for me to dedicate my books to Kiko.
Oh,
So I may do that with this one.
Kiko and Kiko's Bones.
Yeah, Kiko and Kiko's Bones. Yeah, yeah. You should see. I'll have to share the picture sometimes, but I've just been collecting her bones downstairs. So that, it's on the rug. I've got a rug and like a coffee table. There's just a massive collection of bones there now. Because
Now
just
be careful what you save because what if a shredder or a post-it
yeah,
note and
yeah.
they find something and they're finding these bones in there. So be
Oh, I
careful
know.
what you
Yeah, yeah.
save now.
Could be human
Yeah,
remains.
that's right.
Yeah.
Kiko the mass killer. Yeah. Or you're the mass killer. You're just
Well, yeah,
using
be me, won't it?
something. Yeah.
Yeah, yeah. Yeah, but in all seriousness, thank you so much for joining us. We really appreciate it. We're going to have Jenny back again, and we're going to look at
Yeah.
some of these specific
And
infants.
and thank all of you. I have now got friends from the UK that are just making putting the best comments when I make a comment and just thank you all. I enjoy it. The only thing is that we don't speak the same language.
Well,
Can
it's
you
pretty close, isn't it? It's fairly close.
this what I'm wearing here is not a jumper. That's a sweater.
But,
A
well,
jumper is something, it's a person that jumps, okay?
we do say sweater more commonly than
Well, but you call something a biscuit when it's a cookie or oh come on.
there is a
Soccer,
different there is oh, it's got I mean we can't I've got to put my foot down on football. I mean it is football.
no, sorry. Sorry.
Only Americans could have a game where you pick the ball up and you throw it to someone else and they catch it and you call it football.
But see, that's what makes
I put
America
that to
great. You can't understand us,
well, that's
right?
true. That's true.
But
But yeah,
no, football. Yeah. We call you and we enjoy watching. We used to back in the 80s, we loved your soccer hooligans. We call them the
mm,
soccer hooligans because
yeah,
it
yeah,
just
yeah.
reminded us a bunch of drunk things too. So we actually liked you guys.
Yeah.
Stayed
No, no,
love.
I mean I've got loads of American friends.
Yeah.
From a variety of places, and it's strange sometimes to me because I mean I could maybe get a bit of a false impression. I don't know, but I probably know more Americans than I would say 99% of people in Britain, and every single American I know is really intelligent. And the other thing as well is they all know loads about Britain. They're not insular at all. They all know loads about
Well,
Britain.
but you guys started us.
Yeah.
I mean, and again, and when we in wars, you couldn't have asked for a wonderful thing. And let me tell you, and I want to thank you from the American people. On 9/11 was the most horrendous thing that's ever happened. I mean, it had to be just like what you guys with the Blitz. And your queen, she took away what hundreds of years of thing. It's never been done before. She played the United States anthem at Buckingham Palace with her guards. And she stood there with Prince Philip and her, stood there together and did that on 9/11. We have never forgotten. I have never
I didn't
forgotten.
actually know that. But
Yes, it was
yeah,
like
no.
presidents. It was like you could not do another national anthem I get one of the guards, with the big bearskin hats and stuff.
Mm.
At Buckingham Palace, you could
Yeah.
not play unless it was a visiting head of state or something like that. She took that away and says, "Today, the day after 9/11, you are doing the Star Spangled Banner, and I am going to stand out there with my husband and listen to it." We
Mm.
have never forgotten. We
Yeah,
have
well,
never
that's
forgotten.
that's nice. That's nice. Anyway, I'm gonna let you go now.
All right, thank
As I
you.
say, we'll have Jenny back to look at. We're going to look at some of the. I think we'll look at the twins first, don't you? Child A and Child
Okay,
B.
send
Yeah,
me later and just,
and
just
we'll have
remember,
her back at some point
it's
soon.
it's soccer, not football.
Okay, okay. Well, we can discuss that as well. Yeah,
Bye.
take care, Jenny. Thanks for coming. Really appreciate it.
Bye.